Hello, everyone. Welcome back to another live session of our NCLEX review. We are on day 40 of our 90-day free NCLEX review sessions, and we'll be tackling a wide range of the nursing concepts. So we are still doing the medical surgical nursing concepts at the moment. And we are also inviting you to enroll into our NCLEX course at a website. Please drop by at www.stancoast-nclexcoaching.com, so you'll be able to access our on-demand videos and also the 3,000 NCLEX questions plus the 200 NGN test questions, and you're gonna really build your confidence before you're gonna take the RN examination. Now we have AGI TV in the room, Roberta and Melrose, and I hope that I'm not going to mispronounce your name, Nua Kayo. And Virtuous Lady, welcome to the classroom. I hope that you had a great day today. And so let me just read into AGI's question or comment here. Before we proceed today, can you kindly elaborate on the disease that need interdisciplinary therapy? Well, that is kind of a complex question because there are so many disorders that would really require, and I think 99% of these, or probably 100% of these problems will really require interdisciplinary collaboration or therapy. If we're talking about cancer, it's not just gonna involve nurses, but also the other healthcare team members, cancer specialists, surgeons, radiologists, pathologists, and same thing with the cardiovascular problems. There's many things, or many people will be involved here, and other interdisciplinary members, nutritionists. We also have our physical therapists that will help us in treating the patient. So I wish I could have much more of like a narrower, what do you call this? A more specific rather question regarding what you're trying to point out, because like I've said, the disorders will really require everyone in the healthcare team to work on this patient. The same thing with the neurovascular. And so, yeah, give me another question, or much more specific question with regards to the interdisciplinary member involvement. And so, guys, again, please don't forget to hit the like button and make sure that you subscribe to our channel, and also share this to your friends who are reviewing for the NCLEX. All right. Now, today we'll be talking about the disseminated intravascular coagulation. Today, of course, with a follow-up NCLEX test questions. We're going to do a lot of exercises today with the different test types. We've done so many of the matrix multiple choice in the past days, but today we'll be doing a little bit differently. Okay. Now, for the DIC, this is a common disorder that can happen to anybody, especially for those who are critically ill. And this is a problem that can occur when your body's clotting system goes a bit haywire. So instead of clotting only when it's needed, the tiny clots can form all over your small blood vessels. Okay? Again, your clotting system goes a bit haywire. It's getting dysfunctional. And the DIC is basically described as the consumption, the overconsumption of the platelets and also the clotting factors. There is a increasing need, or basically just running out of these substances like the platelets, fibrin. So let's just simplify it. Platelets, fibrin, and also clotting factors. So these are the substances that will be used up in DIC. So the body will not be able to replace the lost or consumed or used clotting factors, or let's say platelets that have been destroyed, or let's say the fibrin. So the body will not be able to compensate for that rapid loss or destruction of these substances. Now, what are the following mechanisms in the DIC? Well, this is going to activate the clotting process, which is going to be really abnormal. All right, so that is one, and this will lead into the microthrombi formation. So there is going to be involvement of the small blood vessels, the capillaries in the body. They're going to be clogged up because of these little clots that will be inside these little blood vessels. All right, so there is going to be a microthrombi formation, and with that, this is going to use up all the platelets, the fibrin, the clotting factors, and eventually can lead into what we call as fibrinolytic mechanism. And so these clots not only will block the blood flow, but also will kick off the process where they can start breaking down too quickly. Okay, so the clotting doesn't end there. There's also what we call as fibrinolysis. And this can lead to a weird situation wherein the person will end up bleeding in some places, but clotting in others at the same time. And this is a problem that is going to, again, occur mostly in really sick patients, but it can also happen to healthy individuals as well, depending on what can trigger it. And so, as we're going to describe DIC, this is basically a double-edged sword because it can mess up the clotting and also the bleeding all at once, and it's really gonna make the treatment very difficult. Okay, now let's talk about the causes of the DIC. What do you think can lead to that? Well, there's many. One of those would be the infection, and more often this is going to be caused by the gram-negative type of infection, and also if the infection is not really treated timely, then this can lead to that DIC. Now, if we are going to talk about some obstetric problems, let's say, for example, embolism, amniotic fluid leak into the maternal circulation, especially when the mother is delivering that baby, and with that complication, that amniotic fluid can go into the bloodstream. We call that as amniotic fluid embolism, and it can also precipitate the disseminated intravascular coagulation. Now, another is the muscle tissue injury that is going to be, let's say, a major part of a body has been traumatized. So when this happens, this will trigger the DIC, the cascade of that abnormal dysfunctional clotting. And also in the case of malignancy, when a person gets cancer, this can really mess up with their clotting as well, especially with the lung cancer, or let's say pancreatic cancer or prostate cancer, or maybe bowel or intestinal cancer. This can also lead to the DIC. And the same thing with a shock, or let's say circulatory collapse, wherein the blood pressure can really go downhill and the body will not be able to help supply the oxygen and the blood into the various organs. And this can now alter the clotting mechanism as well. It can trigger the dysfunction of the clotting system. Now, another is maybe the exposure to a snake venom, especially rattlesnake. This can also lead to the impairment of the clotting factors, which can kick off the DIC. Now, we're going to have to talk next about the different mechanisms here, especially with the DIC. So let's simplify the pathophysiology of the DIC here. And as we have talked about in the previous slide, there are many causes, right? And one of the three major causes are the following. We got the sepsis, or it could be the blood vessel injury, or maybe in such a case there is a huge area of the body that has been traumatized, or let's say involving the muscle, this can now lead to that injury, which will cause the release of the tissue factor. So what is this tissue factor? Well, this is a protein that is found outside of the blood vessels in the tissues. And when the body tissues are traumatized, then it can get exposed to the blood, and then it will now start doing the clotting cascade, which is now going to lead to a series of steps that will lead to clot formation. Okay. Good morning, everyone. For those who just came in, welcome to the classroom. Now, with the release of the tissue factor, again, this will now cause the thrombosis. We're going to talk about the small blood vessels inside the body with the clots getting lodged into the small circulation. This can impair the blood supply to the distal part of the body as well. Now, let's just stop right there, as we're going to talk about the result of the blood vessel injury. If there is what we call as endothelial injury, what do you think can happen here? Well, it can lead to the clumping of the platelets. It will activate the platelets to go into that area where the injury is. And it can also lead to some more of the thrombosis, okay? So this will complicate things much worse this time. Now, what's going to happen when there is now the blockage of the small blood vessels inside the body? Well, again, we're going to talk about a decrease in the blood flow to that area, which will now cause ischemia to the tissue. It will decrease the blood supply and oxygenation to that organ. So again, we're going to think about a dysfunction in the organ function. Okay, so we're not going to specify really at this point, but in general, when there is poor blood supply, poor oxygenation to that particular tissue that has the thrombosis, then expect that there is going to be a lack of function. Oops. Okay, now let's talk about the release of plasmin. So what is this? This is going to be activated, right? Especially with the thrombosis. So what's going to happen? This is going to activate this substance or enzyme we call plasmin. This is an enzyme that breaks down the mesh of proteins known as the fibrin that's supposed to form the blood clots. Now, when this is going to be activated, this will lead into what we call as the fibrinolysis. But before we're going to go to do that, this plasmin activation can actually cause the breakdown of the clotting factors inside the body, okay? And when there is now breakdown of those clotting factors, what do you expect? They're no longer functional at this point, and so it can lead to bleeding because they're no longer able to act on the clotting mechanism. Now let's move forward here with the plasmin activation. What's going to occur when this is activated? Well, this will lead into what we call as fibrinolysis. And when the fibrin clots break down, they're going to release small pieces of the protein called the fibrin split products. And these tiny fragments can actually mess with the body's ability to form new clots and making them stable. So supposedly they're supposed to stop the bleeding, but here with the breakdown of these with a fibrinolysis rather, this is going to cause more fragmentation, okay, of the products, and then this will really mess up with the body's ability to form clots. So this will now result into reduction of the clot formation, and eventually will lead to the bleeding. All right. Now, as we're going to go along here with the occlusion inside the blood vessels, this will lead into what we call as hemolytic anemia, for the reason that the clots inside the blood vessel can actually damage the red blood cells that will pass through this very tiny blood vessels. Okay, so let me just kind of represent that. So possibly with the blood clots occluding into that very tiny blood vessels, and we know that the red blood cells will be circulating to the bloodstream. With this scenario wherein there is now blood clots inside the small blood vessels, this can actually damage the red blood cells as they're going to pass through that area where the thrombosis is, and it can lead into the breakdown of the red blood cells. Okay, so this is what we call as hemolysis. So this is going to lead into the drop of the red blood cell count, also the hemoglobin and the hematocrit, if there is massive hemolysis in DIC. Now, when there is a reduction in the circulating or healthy red blood cells, well, what do you expect with the oxygenation? This can further complicate things, as the person will be lacking that blood or lacking the oxygen that's supposed to perfuse those body tissues. Now let me get rid of this one. So hemolytic anemia can occur whenever there is microvascular occlusion, and also when there is going to be microvascular thrombosis. This can also lead to the massive consumption of all the platelets, the clotting factors, and this will leave the body really, in short, bankrupt of these substances. So what do you think can happen if the person will end up with deficiency in the clotting factors and the platelets? Well, of course, we're going to expect that they're going to bleed out. Okay, so the DIC itself really is going to be a combination of the widespread thrombosis and also bleeding at the same time. And this is really going to make the treatment very difficult, and you really need to keep your patient safe in order to prevent any more worsening of their condition, especially that they had that bleeding tendency. We don't also want that our patient will become immobile because of the increasing risk of thrombotic episodes. So at least we're going to have to give them some form of physical activity that will not predispose them to much higher risk of embolism, or let's say thrombose formation. Okay, so I hope that you're able to pick up the concept about the DIC here. Again, there is a deficiency in the clotting factors, the platelet, and there is a lack of the supply in this disorder. The body will not be able to replenish what has been lost. And so our treatment here will be very critical. We got to have to do a lot of the management, especially with the bleeding itself. We don't want our patient to be hypotensive as well. And definitely we're going to have to protect our patient from any more of, what do you call this? More blood loss, in order that it will not run short of any more of the platelets. Now let's talk about the assessment findings here in our patient with the DIC. Well, you're gonna see this patient with the ecchymosis, which are actually large bruises, also petechiae, which are the tiny red spots, and they can occur because of the deficiency of the clotting factors. There's already overconsumption of those clotting factors. This can lead into spontaneous bleeding, which is going to be affecting the lining of the mucosa as well. So if this is going to injure the mucosal lining of these GI and also the genitourinary tract, then this can also be manifested as urinary bleed, or it could be GI bleeding or rectal bleeding. All right. Now, talking about our patient that may have some IV access, or let's say central line, and so when they're going to go into a DIC, what we're going to observe will be oozing of the blood from the insertion site. And so we're going to make sure that we're monitoring into these sites to prevent any more of, we're going to make sure that we're going to have to stop that bleeding, okay? Now, also here, we're going to have to observe the patients for any more thrombotic events. We're going to have to check our patient for any signs of blood clot. And also if there is a obstruction of that blood vessel, let's say if it's going to affect the kidneys, then possibly it can lead to an impairment in the renal function. Okay, so we're going to have to monitor a patient for their urinary output, the creatinine, the blood urea nitrogen will be monitored as well. Now, this DIC can also lead to multiple organ damage, such as the central nervous system, or could be the kidneys. And so if the blood clot can block the blood vessels in the central nervous system, or especially in the brains, then our patient will manifest those manifestations like the aphasia, those typical manifestations that you will see in a stroke patient. Okay. Now, for example, okay, so when we're talking about the CNS or the brain thrombosis, again, we will be seeing many manifestations. There will be confusion, disorientation, or there could be significant changes in the cerebral function. Okay, what is GU? All right, GU is genitourinary. Genitourinary. GI, gastrointestinal. Question from AGI TV. So DIC versus hemophilia are the same? No, quite. Because hemophilia, as we know, they have two types, right? There's hemophilia A and B. And the deficiency is specific to that clotting factor, okay? Which is the antihemophilic factor. And so they are not the same. They might manifest similarly, but talking about the deficiency, no, they're not the same, JJ. Okay? All right. Again, for those who just came in, welcome to the classroom, guys. Now, we'll talk about the diagnostic tests that we should be able to identify, guys. I have so many stuff prepared for you for the follow-up exercises. So I really want you to pay attention into the diagnostic tests so that you can differentiate what's really needed for this type of coagulation disorder. So first things first, we're going to talk about the platelet count. Well, you'll see there already that the platelet count is decreased in DIC. Now, I really want you to recall the normal value of the platelet. Okay, so what can you recall about the normal range? It ranges from 150,000 to 450,000 per microliter, or in some other books they will put per cubic millimeter. All right, and of course when we are talking about DIC, what you will see in this patient will be a significant drop, less than 100,000. Some cases in the severe form, probably 20,000. And that is very significant. And so why is there thrombocytopenia? Like I've said earlier, there is now an overconsumption of the platelets, right? Why? Because of the widespread activation of the cascade. This is going to cause the platelets to gather into that area where they're congregating. And so with that the microthrombosis, yes, the platelets will be utilized, will be consumed in in a higher rate. So the body will not be able to replenish the consumption of the platelets that have been used in the microcirculation. Okay, so remember about that microthrombosis. This will lead to the excess usage of the platelets into those tiny blood vessels. Now, we'll talk about the next laboratory testing, which is the prothrombin time. Now, whenever you're going to encounter a diagnostic test, always test yourself, guys, in order that this will retain in your subconscious. Make sure that you always recall, hey, do I still remember about the prothrombin time? Or let's say the platelet? Always do that, because as soon as you're going to keep digesting or regurgitating those concepts, it will retain in your brain much more. Okay, so the prothrombin time usually will range from 11 to 13.5 seconds. In some sources, it will probably state 11 to 15, but I'm using 13.5. And again, with the prothrombin time, it will be prolonged. Simply means that it will exceed the upper limit 13.5. There is prolongation of the prothrombin time. Now, why is there an increased prothrombin time? Well, we know that there is now excessive consumption of the clotting factors, and with this, it will also cause the depletion of the other clotting factors, I should say, and it now will prolong the time of, let's say, the bleeding as well. And it will impair, or it can also elevate the INR, as new clots will be formed. Okay, so it doesn't stop. And so there is now overconsumption of those platelets plus the clotting factors. And so this prothrombin time will be much more prolonged. Now let's talk about the APTT, the activated partial thromboplastin time. Now recall about the value. Let me erase that. What is APTT? Normally, it ranges around 25 to 35 seconds. And again, you probably would see some slight differences from this value with the other sources, maybe a difference of 5 points or 10 points. But it really depends on what laboratory has been used for that reference. Okay. Now, why is there decrease or prolongation of the APTT? Well, basically, the APTT is going to tell us that there is already a depletion of the clotting factor, okay, which will now end up giving us a higher number in the activated thromboplastin time. So it simply means that the blood is less viscous. So it's like the body getting its own dose of a blood heparin, right? So it's like taking a heparin, but there's no heparin. It's just that the blood is so thin, super anticoagulated. So that's what it basically means. Blood is very thin, or there is what we call as hyper anticoagulation. I'm just making up that word, but just to give you an idea that the blood now is very thin. It's not going to be able to form newer, what do you call this? The body will not be able to stop any bleeding anymore if there is going to be formation, or if there's any cuts or any blood vessel injury. So it will not be able to deal with that newer bleeding. It will not be able to stop that injury. Okay, now let's talk about the fibrinogen level. So what is this? This is going to be increased or actually decreased, guys. What is the fibrinogen? Well, as we know in the past, that fibrinogen is a substance that is essential in the clot formation. And in DIC, there is consumption of the fibrinogen. Increased consumption of fibrinogen, as it is going to be converted into the fibrin in response into the widespread clotting. Okay, so again, there will be too much usage of the fibrinogen because there is a need to convert the fibrin because of the widespread thrombosis. Now, as we are going to recall the value here, supposedly the fibrinogen's normal value is about 200 to 400 milligrams per deciliter. That is the normal value. So in a DIC, your patient's fibrinogen will be much lower, maybe in the 80s or low hundreds, or it could be less than 50 milligrams per deciliter. Okay, again, in DIC, there is overconsumption of the fibrinogen because of the widespread clotting. Then you will see that the level in the bloodstream for this substance is going to be acutely diminished. Now, guys, please don't forget to pay attention because there's more here. Another testing that will be able to help in the diagnosis of the DIC is the D-dimer. What is this testing? The D-dimer basically is a product of fibrin degradation. Let me change that to a pen. A product of fibrin degradation. And this is actually going to reflect an ongoing breakdown of the blood clots. Reflects ongoing breakdown of the blood clots. Remember about that plasmin activation, the fibrinolysis? Yeah, and that is why the D-dimer is going to be elevated, which basically would signify that because of the massive thrombosis, there's also that breakdown of those blood clots. So when there is a higher rate of the breakdown, then the D-dimer value is going to be elevated as well. Okay, so I don't know if you are familiar with the D-dimer in the past, but the D-dimer is going to be elevated in cases, let's say, DVT or pulmonary embolism. And I actually included this in my lecture about these two topics. Again, why there is increased D-dimer? Well, because of the presence of the blood clots, the body will try to break the clots down. And so the value in the D-dimer will also be higher. All righty. Now, let's talk about another testing that will help diagnose DIC. So what do you think that is? Well, there is what we call as the peripheral blood smear. And this is going to show those schistocytes. What are these schistocytes? These are what we call as fragmented red blood cells. Fragmented RBC. Remember about that thrombosis I drew earlier about the blood clots in the microcirculation in the capillaries, and we have the circulating blood vessels that circulating red blood cells rather. They're going to have to pass through these capillaries, right? And so if they're going to be passing through this very narrow passages, of course, being exposed to these blood clots, for some reason, these red blood cells will get injured and they will hemolyze. Remember about that? They're going to break down. There is what we call as hemolytic anemia. And so this is going to be reflected in this testing, peripheral blood smear. It will reveal the schistocytes, which are those fragmented red blood cells, as they are going to pass through the occluded blood vessels. All right, so this is basically going to give us an idea that there is an ongoing microvascular thrombosis. All right? Reflex, ongoing microvascular thrombosis, and hemolysis. All right, I hope that you are capturing these very important explanations why there is formation, or where there is presence of the schistocytes. Again, this reflects the ongoing thrombosis and also the hemolysis of the red blood cells. All right, here, D-dimer, you need to know that. Peripheral blood smear, fibrinogen, pretty much everything here is very important in order that you're going to really understand the severity, the seriousness of the DIC. Okay, don't ever miss remembering this important concepts. Now, what are we going to do in order to treat this patient with a DIC? Well, before we're going to go to do that, I'm reminding everyone to enroll into our NCLEX program that we are offering at our website at Stancoast NCLEXcoaching.com, where you can access our products for 6 months. We have extensive video library that you can use for your own downtime for 6 months. We have so many resources there. Also have our study materials other than just the videos. And yeah, hurry up. We are waiting for you to enroll. Okay, we have a message here from Nijay Nancy. I'm not understanding this diagnostic test. Are you pertaining to everything in the DIC, or are you pertaining to just one diagnostic test? Let me know so I can address that query. I'm not understanding this diagnostic test. Okay, let me know if you did not understand the whole thing, and we will review after, okay? Now, let's move on into the treatment of the DIC. What do you think would be the management? Well, we're going to identify the underlying cause. And that is why it's very important for us to gather important data. We have to really interrogate our patient or maybe family members about the patient's medical history, the current prescriptions that they are using, any over-the-counter medications, or any of the other risk factors or contributory risk factors that may lead to the DIC. Everything. All right, let's go back into the diagnostic test. All right, let me repeat. When we are dealing with a patient with DIC, these are the laboratory testing that will be required in order to properly establish that diagnosis. So during therapy, we expect patient to be decreased. Then if both were in options, which one is to be taken? All right, I'll answer that one later as well. And so here, for the diagnostic test, these are key diagnostic laboratories that will be ordered by your doctor. So platelet. It is expected that the platelet will be decreased because, again, when the DIC is present inside the body, what's going to happen is that it will cause those platelets to be used up in response to that injury. Remember about the pathophysiology here? If you did not capture the concept of the, if you did not understand this pathophysiology, then you're not going to be able to understand the diagnostic test. Now, remember about the major tissue injury, okay? If there is a massive injury into a huge portion of the muscle, maybe, or let's say an injury into the blood vessel, or let's say sepsis, this can cause the release of the tissue factor. Again, please don't forget that. The tissue factor is a protein that is going to be released when there is massive tissue injury. Okay? Now, this will be released into the bloodstream. and it will cause the clotting cascade. But it doesn't end there. It will invite more platelets to gather into that area where the injury is. Okay, again, there is going to be massive congregation of those platelets into the area where the injury has occurred. All right, now this will also cause the clotting factors consumption, and also more platelets will be used up because it will be ongoing. It will not stop. All right. So again, there is going to be what? Overconsumption. Just like when you are, let me think of a good analogy here. I hope it will come out. But again, the platelets will be overly consumed because of the increasing need by the body to deal with that injury. Again, the clotting factors and the platelets, the clotting factors and the platelets will be used up it will be used up in a higher rate or at a higher rate. Now let's go into the diagnostic test here. Again, the platelet count will be decreased. It will be lesser than what we expect, less than 150,000 microliter. The prothrombin time is going to be prolonged, which simply means that our patient's blood that has the DIC is too thin. Very thin. It's like hyper anticoagulated. Okay. Very thin. So it's just like a blood that has been treated with warfarin, or in this case with the activated thromboplastin time, it's like the body is getting heparin. There's just way too much anticoagulation going on, but it's not about the anticoagulant. It's just the way it is because we are running out of the clotting factors. Deficiency in clotting factors. Why there is deficiency in the clotting factors? Because they have been used up already in those injured tissue. Tissue injury, and so there is overconsumption of those clotting factors and platelets, and then it will end up with deficiency in the clotting factors and platelets. So let's just simplify that, okay? But what I'm trying to emphasize here with the diagnostic test, that the prothrombin will be increased, which simply means that it will give us a better idea that there is already less clotting factors that will be involved in preventing the newer, it will not be able to form newer clots if there is a new injury, okay? Now, same thing with the activated partial thromboplastin time, it will reflect that there is also deficiency in the clotting factors. Now, for the fibrinogen level, this simply means that our body has that rapid rate of converting of the, what do you call this? The fibrinogen is being used up already, okay? So it is converted into fibrin because of the widespread clotting. Decreased due to rapid conversion into fibrin. All right. And this is caused by the widespread clotting. And so the fibrinogen will be greatly decreased. Again, the D-dimer is an indicator that there is a presence of thrombosis. And again, the D-dimer is our diagnostic test that there is ongoing degradation, or let's say breakdown of those blood clots. It reflects rapid rate in the breakdown of the blood clots. That's the D-dimer. And then we have the peripheral blood smear, which basically would reflect that there is hemolysis. All right, so I hope that you are capturing that one, AJ, because I don't know what else, how else I could simplify that thought. Okay. Hmm. The question is, so during the therapy, we expect PT and APTT to be decreased. Then if both were in options, which one is to be taken? Well, if we are going to treat the patient with a DIC, okay, what we'll be expecting is a reduction in both PT and APTT. All right, that's what will be the goal. Okay, we want to actually decrease the PT or the prothrombin time. We're gonna have to return or actually have to normalize those higher values. All right, we're gonna have to treat them. We haven't gone that far yet, so hang tight, guys. We haven't been into the treatment phase, so just wait. We'll get to that. All right, now we're gonna talk about the management. So this is where we're gonna have to focus with that kind of question. So what are we gonna do for this patient with a DIC? Well, we are going to treat the cause. Again, identify, is it going to be an infection? Is it a sepsis? Or is it a huge injury to the muscle tissue? Or is it caused by the burns? Or is it caused by the, what do you call this? Amniotic fluid embolism. So we need to identify first what's really causing the DIC so we can treat them appropriately. So that's the first step. Now, we are going to also treat the patient symptomatically. So how are we going to do that? Well, if there's going to be severe bleeding, then we are going to treat the patient with probably packed red blood cell transfusion. Okay. Packed red blood cells transfusion if there is severe bleeding and if the hemoglobin is severely low. Maybe if the hemoglobin is less than 7 or 8. Usually this is going to be this is the criterion why we're going to administer blood transfusion. So if there is a significant drop in the hemoglobin, or let's say the red blood cell count, then we are going to expect the packed red blood cell transfusion, all right? PRBC. Now, another intervention for that or treatment will be to administer the clotting factors. Remember that there is depletion, there is overconsumption of the clotting factors when the DIC happened. And so we are going to replenish that by giving the clotting factor transfusion through the cryoprecipitate. So this is a blood product that actually will contain those clotting factors, or there's also what we call as the fresh frozen plasma. Again, they're going to contain the clotting factors. And this will replenish the lost clotting factors. And this will now help in preventing more bleeding. All right. So like I've said, this will now lead to a much more stable prothrombin time and partial thromboplastin time. Okay. Again, the administration of the clotting factors through the cryoprecipitate or the fresh frozen plasma will be helpful in treating the bleeding tendencies. Because we are running out of the clotting factors and the platelets, we want to stop that. All right, so this will now stabilize our values. So it will no longer be prolonged. The PT will be stabilized. The partial thromboplastin time will also be stabilized here. All right, so I hope that you're understanding now the need for the clotting factors. Now, another thing is that, so here we go. The blood transfusion can be intended for a severe bleeding. For example, like I've said, if the hemoglobin count is less than 7 grams per DL. So expect the blood transfusion to be ordered. And also the transfusion of platelets. Yes, that's another blood product, right? And this is going to be indicated when the platelet count drops less than 50,000 per microliter. So this is our replenishment of the platelet that has been lost with a DIC. Okay. Now the cryoprecipitate is there. The FFP will also be required in order to prevent the massive bleeding. And here we go, guys. Anticoagulation. This is somewhat controversial. I've read everywhere about the use of the anticoagulation. This is only going to be needed. This is going to be used only if there is extensive thrombosis. But again, anticoagulation will not be routinely used if the patient doesn't have massive thrombosis. So that is the caveat here with the idea of anticoagulating our patients. So this is only reserved for extensive thrombosis. So possibly if the patient is now suffering from CNS, maybe they're now manifesting signs of stroke. Or let's say, for example, if the thrombosis is affecting now the kidney, it's probably causing impairment in the kidney function, possibly because of the blood clot lodging into the pulmonary artery, or not pulmonary artery, but the artery supplying to the kidneys. Okay. So if there is impairment of, nope, you're fine. I'm always fine with the questions, but again, I will have to just kind of, what do you call this? Allocate the time as far as the explanation, because I don't want to confuse you guys. And so with the CNS and kidney function, if they're going to be greatly compromised, and that's the time that there will be administration of the anticoagulation. But then again, in an early phase of DIC, anticoagulation is not recommended. Okay. Now we will talk about the IV fluid administration, which is going to be important, especially if there is a considerable drop in the blood pressure. Indicated for decreased blood pressure, maybe there is now massive blood loss, then we really need to stabilize the circulating fluid volume in order to prevent compromise of blood supply to the body tissues. So we are going to expect that as well. All right. What else? We're also going to administer oxygen if the patient will manifest any hypoxemia. We are going to do that, guys, especially in the case of sepsis, massive infection. There's going to be what we call as anaerobic metabolism. Yeah, our patient really will lead into what we call as lactic acidosis. And here, our patient will require more of oxygenation this time. So hypoxemia is an issue in DIC as well. So that's why we're going to have to supplement their oxygen with possibly nasal cannula, or it could be simple mask, or maybe non-rebreather, right? Now, there's so much more that we can do to our patient. Well, what are the nursing actions that we will be providing to this patient with a DIC? Well, what we're going to do here is to make sure we are monitoring our patient's vital signs. This will call for much more frequent vital signs checking. We have to report any unusual or any drastic changes or any abrupt changes into their vital signs. The question says, using FFP, which one is to be decreased among hemoglobin PT to be sure of effectiveness? The question says, using fresh frozen plasma, which one is to be decreased among to be decreased. Says using FFP, which one is to be decreased among hemoglobin? So are you asking how to determine the effectiveness of the FFP treatment? What laboratory study would determine the effectiveness? We will talk about that AJ TV. I have that in my test question as well. So hang tight. All right. So here we are going to check our patient's vital signs regularly. And if there is a need for us to really pay attention, if there is any instability of our patient's hemodynamics, when definitely we're going to have to do some more of that vital signs checking. All right. And in this manner, or in this scenario, if we are suspecting DIC, their hemodynamics is gravely compromised now. And this is not going to be a patient that is not appropriate to be placed in the med-surg setting. Okay, so this is a very complex scenario. We need to transport this patient into a higher critical care, right? ICU, or could be progressive care unit, because they have lesser nurse-patient ratio, and they have much more skill in managing this type of patients. And so our patient here will require much more of frequency in checking their vital signs. Everything: blood pressure, heart rate, temperature, respirations, oxygen saturation, even the monitoring of their intake and output will be much more frequent in order to check for the organ function, especially the kidney. We need to keep an eye on how well the kidneys are still working, as we know that the kidneys will start to shut down if there is going to be low cardiac output. Now, another thing that we need to do is to monitor our patient about their bleeding, check for those insertion sites, catheters, IV catheters, central lines, check for any leaking of the blood from these insertion sites, and make sure that we are incorporating the bleeding precautions. Okay, we have to watch for any signs of bleeding. It could be just ecchymosis, or it could be hematoma, or it could be petechiae, or it could be bleeding in the urine or the rectum. Okay, so you will have to pay attention to any exit points where this bleeding can be seen. Okay, now we also need to be cautious, especially for the females. We're going to have to manage their menstrual bleeding by how? We are going to monitor the pad count. Yeah, Mary, you're correct. Check bleeding from all orifices or any exit points. Especially for those women still having the menses, we need to make sure that they are monitoring, or we are counting the pads. We are weighing them, so we will be able to approximate the amount of blood that is being lost. Okay, and possibly this is going to be treated with the use of hormones to suppress menstruation. Hormone administration to suppress menstruation. Okay, so that is one way of managing the irregular or maybe heavy bleeding into these women. Now, we're also going to have to administer blood products. Like I've said earlier, it could be in the form of packed red blood cells. It could be the administration of platelets. Okay, it could be in the form of the fresh frozen plasma or the cryoprecipitate. So these are the things that we're going to have to expect in the transfusion. We're going to talk more about the blood transfusion, guys. This is a huge monster that we need to talk in detail in the next session. All right, so the blood transfusion is a big thing in the management of DIC. Now we're going to also talk about the clot management. What are we going to do with that? Well, we will be promoting circulation in our patient. We're not going to let them just do complete bed rest, because that will also worsen the thrombosis. we're going to encourage them to do some gentle exercises, regular positional changes in order to maintain circulation. So that's what clot management is pertaining about. Okay, so that's related. Frequent position changes. And then we're also going to have to monitor the organ function. Again, we'll check on the liver function, also the kidney function, and also the what? Brain function. As we all know that the patient is having massive thrombosis, we want to make sure that these vital organs are going to maintain its vital function, I should say. So how are we going to do that? We're going to check the LFTs here for the liver. We're going to have to check for the creatinine, BUN, for the kidney function. And of course, for the brain function, we can do this by regularly assessing the patient's level of consciousness, also their cognitive function. Okay. We're going to keep assessing their neurostatus. Okay. Now, part of the care here will be to monitor for any signs of vascular occlusion. And how are we going to do that? Well, we'll have to check for capillary refill. Check for capillary refill, especially in the distal extremities. Find out if there is any coolness to the skin. Let's say poor perfusion. There is now pale color to the skin because of poor blood supply to that area. So that would be very crucial for us to check. Okay. If the occlusion is going on into the distal extremities, then we need to do the circulation, motor, and sensation check. All righty. Let's talk about this time on the test questions. So I'll be doing some more explanation as we go along with the test questions. All right, so here we go. First test question. Please pay attention. Mrs. Smith, a 58-year-old female, presents to the emergency department with sudden onset of unexplained bleeding and bruising. Her medical history includes hypertension and a recent infection. She has no known history of bleeding disorders. Upon examination, she has petechiae on her lower extremities, hematuria, and reports severe shortness of breath. Based on the clinical scenario, what is the earliest clinical manifestation in Mrs. Smith, indicating the possible onset of acute disseminated intravascular coagulation, or DIC? All right. Question stated that the patient is a 58-year-old female presenting to the ED with sudden onset of unexplained bleeding and bruising. And the medical history includes hypertension and recent infection. No known history of bleeding disorders. Upon exam, she has petechiae in the lower extremities. There is blood in the urine, and she is reporting shortness of breath. That is severe. So, what is the earliest clinical manifestation in this patient, indicating possible onset of acute DIC? Guys, is it severe shortness of breath? Is it, this is a multiple choice, guys. This is not select all that apply. If I don't indicate select all that apply, then this is only a multiple choice. I'm making this more complex by giving you 5 choices. Yeah, not just 4 choices, but it will be 5 choices for the multiple choice. All right, so you're only allowed to select just one. Is it shortness of breath that is severe? Is it bleeding without a history or cause? Or is it orthopnea? Or is it hematuria? Or sudden onset of confusion? Now, what is being asked here? Earliest, right? What did it say? What is the earliest clinical manifestation? This is what we are looking for, guys. So you're answering number 2. I've seen number 5. Okay, we'll see what this is. Well, the correct answer here is the bleeding without a history or cause. And this is the earliest sign of DIC. Let me explain. Answer is 2, bleeding without history of cause. The reason for that is because the disseminated intravascular coagulation can lead to that widespread activation. Remember, once there is already that injury into the endothelium, or let's say sepsis, or could be muscle tissue injury, this is going to activate the clotting cascade. And this is going to use up all what it could find, all the platelets, all the clotting factors. It will now congregate into the area of injury. And so the person will end up with a deficiency in all those clotting factors. The platelet, the clotting factors will be greatly low, okay? Or they will be decreased, okay? So that person will be bleeding without history or cause. Kind of weird how it's being termed, right, in the textbook, without history of cause. But again, the reason for that is the overconsumption of the platelets, the overconsumption of the clotting factors. The body is running out of those substances. If you had answered shortness of breath or severe shortness of breath, this can also occur in the DIC. If the DIC is affecting the lungs, maybe there is pulmonary embolism, but again, it's not typically the earliest sign. Not typically the earliest sign. So the severe shortness of breath, again, can be caused by the obstruction of that clot in the pulmonary artery, such as in the case of pulmonary embolism. But again, this is not going to be the earliest sign. What about orthopnea? Well, when we are talking about orthopnea, this is much more related to cardiac conditions, let's say congestive heart failure. Okay. And again, this is going to occur as a complication from the PE. All right. Let's say, for example, if the patient has a massive pulmonary embolism, maybe the blood clot is so big that it's obstructing that large pulmonary artery. And so it can lead into hypertension in the pulmonary arteries, which will lead into the right-sided heart failure. But again, this is not going to be the earliest sign. It will be happening towards a later stage when there is severe DIC complicating into pulmonary embolism. Now, what about hematuria? This simply is the presence of the blood in the urine, right? But typically, it will follow after an initial bleeding, okay? It will follow, or it follows after initial bleeding, which is what we have, okay? So it can follow to petechiae, or let's say unexplained bleeding. Now, sudden onset of confusion. Well, this is a sign that the patient may have microthrombosis in the brain. But then again, this will not be an early sign. This is a late sign. Okay? So try to eliminate these possible manifestations in DIC. Again, we're looking for that early clinical manifestation, which is the bleeding without history or cause. Hang tight, we got some more. Question number 2. Mr. Johnson, a 65-year-old male, has been diagnosed with a DIC following a severe systemic infection. His current symptoms include extensive bruising, there is hemoptysis, hematuria. His lab results show prolonged prothrombin time, and activated partial thromboplastin time and decreased fibrinogen levels. And again, our patient had severe systemic infection. It complicated into the DIC. Now his lab work is showing prolonged PT. There's also prolongation of the activated partial thromboplastin time, and the fibrinogen is decreased. So these are the labs that are seen in patient Johnson. Now, what else? I think I've captured everything there. So let's move on to the question. Which of the following treatments is contraindicated for Mr. Johnson in managing the DIC? So what interventions, what treatments will you expect to be contraindicated for this patient with a DIC? What do you think would be the answer? Which of the following treatments is contraindicated for Mr. Johnson in managing disseminated intravascular coagulation? What do you think? Contraindicated. Please take note of the word contraindicated. What do you think would be that treatment that should be avoided in a patient with a DIC? Okay. What do you think? Two and three. Well, I guess I made a mistake here. I put the only here. So partially you could answer 5, but I made a mistake, honest mistake about adding only. Okay. Supposedly there was no only. Okay. So let's eliminate that one. So eliminate only. Erase only. So I want you to answer this one objectively, I should say. Eliminate the word only. Okay. What do you think would be contraindicated? Your answers, I'm seeing 2, 3. 5 will be almost neglecting patient. Yeah. But like I've said, we're eliminating the only word there. So let's just put that as providing supportive care. Okay. So basically, this is a multiple choice, but I created 5 options. Okay. This is not really a SATA. This is only a multiple choice. We are going to find that treatment that is contraindicated. Okay. So take a look into the situation here. The patient has extensive bruising, hemoptysis, hematuria, prolonged PT, APTT, decreased fibrinogen levels. So take your pick. As I have said earlier, guys, that in such a case when there is massive, what do you call this, DIC, remember that anticoagulation with the use of the anticoagulant, it could be the heparin, but not the warfarin. This is our answer this time. Administer warfarin Coumadin, because this is very unsuitable as far as treating the coagulation factors. It's already compromised. However, the heparin will prevent more of the thrombosis. Quite like a weird mechanism, but as far as with the use of the heparin, the reason that heparin is going to be utilized in such a case wherein there is massive DIC, this is going to prevent further blood clot formation, okay, when there is severe thrombosis, but not the warfarin sodium, okay? Now, what about number one? Treating the underlying cause. This is going to be eliminated. What about providing supportive care? I eliminated the only right there. So this is going to be a positive nursing or treatment rather. What about replacing depleted blood products? This is also a good intervention, right? So here we go, the administration of heparin and the administration of the warfarin. So we are going to choose between the lesser evil here. And that would be, we're going to eliminate the lesser evil, which is basically the heparin. So our answer here will be the administration of the Coumadin in the treatment of the DIC. Okay, so what do you think about the DIC? Remember that the warfarin really is not going to work in the acute thrombotic episode. It will not. It will not work as rapidly compared to the heparin. The onset of the warfarin is much late compared to the heparin. The heparin can work within less than an hour. And so it will be able to treat the DIC if there is massive thrombosis, whereas the warfarin will take about 2 to 3 days to work in preventing more clots. Okay, so the rationale here, warfarin takes 2 to 3 days to work, whereas the heparin is rapid acting, can treat massive thrombosis. Let me rewrite that. I don't have enough space. Again, the difference between the two is that the heparin can act much faster. The onset of action is faster in heparin. Faster in heparin. It can treat massive thrombosis. It will prevent more clots from forming, whereas the warfarin will take days before it can work. Okay, so that's the reason why we are going to be why we are choosing number 3, which is administering warfarin sodium. Okay, it is going to be contraindicated, whereas we're gonna consider heparin as one of the mainstays in the treatment of massive thromboembolism because it can work faster to treat the thromboembolism, whereas this one, or thrombosis rather, thrombosis, not thromboembolism. Or yeah, maybe in such a case we are trying to prevent any more pulmonary embolism, or let's say cerebral embolism, then that can work because that was with that kind of a reason. But as far as the warfarin, it will not be indicated for this situation when there is urgency to prevent thrombosis. Okay, the onset is going to be our main issue here. The onset of the medication is later, okay, with the warfarin. So I hope that you are able to understand, and I'm seeing Masabara, thank you. So thank you for allowing me to explain. It's very complex, guys, now that we are having to resolve this 5 options, okay? Don't worry, I still have more SADA in the next few slides. We are dealing with a multiple choice that's like 5 of them, so it's more complex. Let's talk about number 3 this time. Miss Lee, a 45-year-old female, is in the ICU with a diagnosis of DIC secondary to sepsis. Diagnosis of DIC. She is showing signs of microvascular thrombosis, including confusion and cyanosis in the extremities. The nurse should assess Ms. Lee for which clinical manifestations associated with microvascular thrombosis in disseminated intravascular coagulation. Thank you, James. So the item stated, the nurse should assess Mrs. Lee for which clinical manifestation associated with microvascular thrombosis in disseminated intravascular coagulation. Which manifestation should be assessed in this patient? Is it hemoptysis? Is it focal ischemia? Is it petechiae? Is it hematuria? Or is it elevation of the liver enzymes? What do you think would be the assessment? Please don't forget about the presentation of the patient, guys. Please don't forget. Your patient has now what? Microvascular thrombosis, confusion, cyanosis in the extremities. What do you think would be that assessment finding? I'm seeing 3, 2, 3, 2. I know, guys, you're working hard with your brain today. I know that you're trying to analyze. Very good. I want that. You are trying to analyze this time. So, you gotta choose what's really happening here, especially that it's now causing confusion. Signs of microvascular thrombosis, cyanosis in the extremities. All right, let's go through the options here. Hemoptysis. What is that hemoptysis? Well, this is going to be a manifestation, a bleeding manifestation of coming from the lungs, right? Possibly. But this is kind of like vague. Is this caused by the thrombosis itself? Maybe not. So this is going to be like a vague assessment. Yeah, it is a bleeding sign, right? But is it caused by the microvascular thrombosis? We don't know. We don't know. What about focal ischemia? Talking about the focal ischemia, what does that mean? It simply means that there is a obstruction of the clots inside the blood vessels to the specific areas, okay? Focal ischemia simply means that there is what? Obstruction of the blood flow to specific areas in the body. So it could be the brain, or it could be the cyanosis integumentary system, a particular part of the skin. So this is what focal ischemia actually means. Again, there is thrombosis in those tiny circulation, okay, the capillaries. This is going to obstruct the blood flow. And so possibly the patient will now manifest the confusion, right? Disorientation. And if it's going to be specific to the lungs, well, what's going to happen? There can be what? Poor oxygenation, possibly because of the pulmonary embolism. Okay. So here we have the focal ischemia, which will be like what we call this. This is actually going to be like an umbrella on all the possibilities of the different microvascular thrombosis. So we have the manifestation here, confusion. This could be a sign that the patient is now having occlusion into the part of the brain. Okay. We have cyanosis, which is going to be possibly a part of maybe an area in the body where there is an obstruction into that body part. There is now discoloration. And so we're going to have to pick focal ischemia. This is much more specific compared to the hemoptysis. Hemoptysis is a possibility of a PE, but we're not quite sure about the source of the bleeding, right? What is really the contributing factor why they are bleeding, all right? And so we're going to focus into the pathophysiology, obstruction of the blood vessels, which will impair the blood flow or the airflow. Now, talking about the petechiae, what is this petechiae? This is basically the tiny pinpoint hemorrhages under the skin. It doesn't reflect thrombosis. Does not reflect thrombosis. Okay, so I hope that you are understanding now why petechiae is wrong. Again, petechiae is an indication that there is bleeding. However, it doesn't mean that there is thrombosis into that part of the skin. Okay, what about hematuria? Hematuria is bleeding in the urine, right? Or in the urinary tract. And so the hematuria is not going to be an indication that there is a obstruction in the blood flow to the kidneys. It doesn't. Now, what about elevated liver enzymes? This is going to occur in severe infections, or let's say sepsis, but is not specific to the microvascular thrombosis. Not specific to microvascular thrombosis. Okay, guys, are you picking up about the microvascular thrombosis signs? Don't neglect about the DIC, which is that hallmark thrombosis. This is widespread, guys. So this is going to be our focus in the assessment and also in the treatment. Now let's move on into the next question, guys. Mr. Davis, a 50-year-old female or male, presents with DIC following a traumatic injury. He is experiencing internal bleeding and his physical exam reveals increasing abdominal girth and signs of hypovolemic shock. Again, Mr. Davis, a 50-year-old male, presents with DIC following a traumatic injury. He is experiencing internal bleeding and his physical exam reveals increasing abdominal girth and signs of hypovolemic shock. Which of the following assessment findings is associated with internal bleeding in disseminated intravascular coagulation? The question states, which of the following assessment findings is associated with internal bleeding in DIC? Is it bradycardia? 2, hypertension. 3, increasing abdominal girth. 4, petechiae. 5, decreased urine output. Again, which of the following assessment findings is associated with internal bleeding in DIC? If you are answering petechiae, is it internal, like visceral bleeding, visceral organ bleeding? Probably not. So I want you to carefully read the question. He is experiencing internal bleeding and his physical exam reveals increasing abdominal girth. Guys, please don't neglect the assessment here. What is severe in this situation? What is really going on into this patient? And signs of hypovolemic shock. Guys, please read the question carefully. Our patient is having internal bleeding with signs of hypovolemic shock. There is a massive bleeding going on inside the body, the visceral organs. So if you're selecting 4, that is huge wrong. Petechiae. That is integumentary. This is superficial. Superficial bleeding. So eliminate this one. If you're answering bradycardia, that is also wrong, because when you have hypovolemic shock, the heart rate will be what? It's going to be elevated. Heart rate is elevated. So we are going to eliminate bradycardia. Wrong. Oops. All right. So this is going to be wrong. Bradycardia is wrong because it's supposed to be elevated to compensate for the low blood pressure. This is wrong. Should be elevated. Okay. What about hypertension? Do you think, yeah, James answered tachycardia. Of course. Thank you. Tachycardia, not bradycardia, guys. What about hypertension? Would that be correct? Is hypertension an expected finding in hypovolemic shock? No, that is also wrong. We're going to X that out. There should be what? Hypotension. All right. What about increasing girth, abdominal girth? We are talking about internal bleeding. Yes, this is what we are looking for. Increasing abdominal girth is basically going to tell us that there is what? Accumulation of blood in the abdominal cavity. Okay. So here we go. Increasing abdominal girth is a significant assessment finding here, guys. Now, what is decreased urine output? Possibly the decreased urine output will occur after all these hypotension, decreased cardiac output can occur, right? So this would be also a good assessment finding, but it will happen after there is decreased kidney perfusion, all right? So this is sign of decreased kidney perfusion. Yes, it can happen, but our assessment finding here, that should be critical to point out that there is intra-abdominal bleeding or internal bleeding. We're going to select the increasing abdominal girth. All right. So, guys, review the signs and symptoms of shock. Heart rate. What do you recall about the heart rate? This is the first vital sign that will increase when there is hypovolemia. First to increase, there will be tachycardia. Along with the respiratory rate that will increase, there is going to be tachypnea. Then this is going to be followed by the blood pressure, hypotension. All right. Please don't forget this, guys. Heart rate will be elevated when there is hypovolemia. Along with the respirations, it will go up. However, with the blood pressure, it will go down because of the decreased circulating volume. Please do not forget this important concept. So we'll be talking more about the different signs, different shock, rather. There are several types of shock. So let me clear this. Okay. Let me see. The answer is in the question. This is tough. Yes, it is tough. So, Najay, I want to ask you, are you getting the reason why we are selecting the, what do you call this? The increasing abdominal girth. Do you Do you get the reason why we should be prioritizing the abdominal girth increase rather than the petechiae? I want to make sure that you are understanding this, okay? I want to make sure that you're really able to use the concept of the science of shock into the scenario, because this is very important. This can be applied to more NCLEX questions. I really want you to understand this, because you will be creating some more errors in the future if you will not properly recall the manifestations of shock. Or even with the hypovolemia in the fluid electrolyte imbalances, you will get this wrong again if you will not be able to utilize the concepts of what do you call this? Especially if there is blood loss or it could be fluid loss, always think about the vital signs, guys. Vital signs, again, heart rate is high priority, respiration, the blood pressure will be lower. If there is going to be fluid loss, or let's say blood loss, always think about tachycardia, tachypnea, blood pressure that is low. Okay, and if we are talking about the pulsation here, earlier during the stage of hypovolemia, the person will end up with bounding pulse. Okay, and towards the later stage, it will be thready. It will be much weaker. So, AGI-TV, it can cause peritonitis. Yes, if there is going to be a perforation or could be a rupture of that organ bleeding into the abdominal cavity, well, of course, it can lead to the peritonitis because of the exposure into maybe the normal flora into those areas that they're not supposed to go, right? So it can lead to that complication, peritonitis. But here, what we are actually worried about is the blood loss, the massive blood loss that is going on. Okay. Yeah, this is very important, guys. Hypovolemic shock, increasing abdominal girth. All right. So our answer again here is increasing abdominal girth. Bradycardia is to be eliminated. That's supposed to be tachycardia. Hypertension is wrong. It should be hypotension. Petechiae is not a sign of internal bleeding. This is superficial. And decreasing urine output. This is going to be seen during the later stage when there is hypoperfusion, decreased blood supply to the kidneys. So we are eliminating this one as well. Okay. Hypovolemia instead. Yes. All right, NJ, I hope that you will be able to use this in the future test questions. Please do. All right. I'm really encouraging you to use this concept in order for you to have accurate decisions in the next test questions. We will have some more. Okay, let's move forward with number 5. A 60-year-old male has been admitted to the ICU with a diagnosis of DIC secondary to severe sepsis. The healthcare team is monitoring his clinical status and lab results closely. Based on your knowledge of DIC, determine whether each of the following clinical features and diagnostic test results is expected or not expected. Thank you, Nejay. The question stated, guys, a 60-year-old male has been admitted to the ICU with a diagnosis of DIC secondary to severe sepsis. The healthcare team is monitoring his clinical status and lab results closely. Based on your knowledge of DIC, determine whether each of the following clinical features and diagnostic test results is expected or not expected. Oops, let me correct that because the numbers here are repetitive 888. Let me change that real quick. Hang tight. Okay. We are on page 683. 683. Let me do a fix on that one. So supposedly this is 9. And then this is going to be 10. All right, so I guess I got that one fixed. Very good. So what do you think about these clinical findings? So I want you to assign whether it's expected or not expected. So please indicate your answers by putting the number of the manifestation and then put here E for expected or NE for not expected. So let me start with the rationalization here. So what is ecchymosis? Remember about the ecchymosis? This is basically the bruising, right, of the skin. Bruising of the skin. And this is an expected manifestation in DIC because of what? Widespread activation of the coagulation cascade. It is going to consume the clotting factors. Consumption of clotting factors. Or let me just shorten that to CF, clotting factors. Clotting factors. So let me see your answers. Ms. Flynn, 7 expected, 1 expected, 3 expected. Mary answered 1E, 2NE. Okay, very good. Melrose, you have 1, 4, 6, 7 expected, 9 not expected. Najay answered expected 1, 3, 4, 6, 7, 8. 2 unexpected. Okay. So let's go through after the ecchymosis. What about hypertension? Remember that when there is a DIC, if there is a massive bleeding, then it can lead to circulatory collapse. So hypertension is going to be not expected. So what you will see instead is hypotension if there is going to be blood loss. Massive blood loss. Now what about petechiae? That is also expected. Very easy to spot. This is a pinpoint hemorrhage. That is a classic sign of DIC. Classic sign of DIC. What about increasing abdominal girth? Yeah, you have already a reference from the previous test item, right? So there is now accumulation of blood in the abdominal cavity due to internal bleeding. Sign of internal bleeding. So this is expected. What about bradycardia? Rapid heart or slow heart rate. Remember about the blood loss? So we are going to expect tachycardia instead of brady. So this is going to be not expected. What about prolonged prothrombin time? What do you think about the prolonged PT? Is it expected? Yes, we already talked about that earlier. The reason? It's because there is overconsumption of the clotting factors. There is going to be thinning of the blood. Expected due to increased consumption of clotting factors. All right. Now, take a look into elevated D-dimer. Let me see your answers. Expected, very good. D-dimer. What is your answer on the D-dimer, guys? Is it expected or not expected? Expected by James. Very good. That is correct. Remember about the massive thrombosis, right? Massive thrombosis. And when there is massive thrombosis, remember about the fibrinolysis. It will now increase the rate in the breakdown of those blood clots. Okay? Massive thrombosis. Remember that the elevated D dimer is a reflection of what? It is a reflection of increased breakdown of fibrin clots. Increased breakdown of clots. So this is an expected finding. What about decreased platelet count? Yes, of course. There is thrombocytopenia. Now, talking about the fibrinogen, let me check your answers here. Did you select fibrinogen as expected? Very good. I'm seeing a lot of 9. Fibrinogen, remember the fibrinogen? Remember about what that is? The fibrinogen is actually going to be decreased, okay? It is going to be decreased, and so this is not expected because supposedly the fibrinogen will be decreased in DIC. Decreased in DIC. Now, what about normal activated partial thromboplastin time? Is it going to be normal? No. Remember what I said earlier, because of the overconsumption of the clotting factors, the activated partial thromboplastin time will be prolonged, not normal. So this is going to be not expected as well. Okay. How do you find this test question? Is it helping you figure out the differences in the manifestation and also the lab data? Is it helping? Because if it's not helping, then probably it's confusing you guys. So I just want you to let me know if this type of question is actually helping you to figure out the different manifestations. Very good. 9 out of 10, 10 out of 10, 9 out of 10. Okay. Esther Solaco, did you mean that it's helping? No, it's not helping, guys. Oh my gosh. All right. Okay, we'll have some more stuff coming up. All righty, let's move forward. Yeah, I'm just kind of spacing out here with like interval with the multiple choice because I don't want to cause some overexhaustion in your brain. Number 6, a 68-year-old male client underwent complex heart surgery requiring prolonged use of extracorporeal circulation, which is basically heart-lung machine. The fancy word, right? And due to the intraoperative complications. Let me reread that, guys. A 68-year-old male client underwent complex heart surgery requiring prolonged use of the heart-lung machine due to intraoperative complications. He is now at risk for complications such as DIC coagulopathy. Which of the following, or actually that's the intravascular coagulation, which of the following lab values would be most critical for the nurse to assess and report to the physician? Okay, what do you think will be that lab value that would be most critical for the nurse to assess and report to the medical provider? What do you think? So I want you to recall, guys, the values. Remember about the value that I've shown you earlier in the diagnostic slide. So here, if you are not familiar with the numbers, again, use the process of elimination. Use the elimination process if you forgot. Elimination process. If you forgot the values. Partial thromboplastin time of 74. What does that mean, guys? I know it is elevated. It is elevated. Partial thromboplastin time. Prolonged PTT. Okay. But I want you to capture what is an indication here that the patient really has severe form of DIC. Okay, we are looking for that lab value indicating severe DIC. These are all. This is the heparin related meds. Of course, we have the partial thromboplastin time, which is actually a diagnostic test, right, to check for the heparin. But here we're just wanting to figure out what that laboratory data that would be the most critical. I know this is abnormal. The fibrinogen is abnormal. The partial thromboplastin time of 74 is also abnormal. Prothrombin time, what do you think about the prothrombin time? 15 seconds. Do you think that this is normal or abnormal? 15 seconds is basically, or 15 seconds is within the normal limit, so it's not going to be a concern. Okay? Not a concern. Supposedly it should be elevated or prolonged, right, in DIC. So we're going to eliminate number 2. Hemoglobin of 13.8. Our patient is 68-year-old. Is it critical? No, it's not critical. Eliminate that one. So you're down to the partial thromboplastin time of 74 seconds or fibrinogen level of 88 milligrams per DL. So which one is worse comparing the two? Which is the worst evil here? Is it the partial thromboplastin time that is 74 or is it the fibrinogen? Please take note. Remember about the partial thromboplastin time. What is the value? Activated partial thromboplastin time, it is somewhere around 35 to 45, right? However, for the fibrinogen, what is the value of the fibrinogen? Let's go back to that slide so we will know for sure which one is severe. Okay, here are the diagnostic tests. Our fibrinogen levels should be at what? That's actually 200 to 400 milligrams per DL. That's the normal value of our fibrinogen. Okay. Yeah. And our value here is only 88. Remember, guys, that actually the fibrinogen level is depleted. It is being used up so rapidly by the body because there is a need to, what do you call this? There is actually extensive consumption of the fibrinogen as it's because of the conversion to the fibrin, all right? There is rapid conversion of, let me rewrite that here, due to rapid conversion into fibrin. This is the rationale that I said earlier. Rapid conversion into fibrin because of the widespread clotting. Widespread thrombosis. Okay? Supposedly the fibrinogen, guys, what is the function? Let's understand first what is the fibrinogen. This is basically a substance that is essential in the clot formation, needed in clot formation. All right. However, in the DIC, since there is now a consumption of those clotting factors, the platelets, there is going to be a rapid usage of the fibrinogen because of the widespread clotting. It's way too low, severely low. That's what I'm trying to explain here, guys. So this is critically low for that 88 milligrams per deciliter. Now let's go back into that scenario. Where are we at? Item, not that one. Let's go back into the, yeah, this is the one. The partial thromboplastin time, which is elevated. This is expected, guys. Expected finding in DIC. All right. The value of 74 seconds is elevated. We know that the normal value in the APTT is what? 35 to 45, right? In a normal functioning body. Supposedly it's only about 35 to 45 or something like that. But this is not a critical value in DIC. Maybe if the value is greater than 125 seconds, then that would be similar to your fibrinogen. But here we're only given 74 seconds. So it is an expected finding. So it will not really gonna require us to call the physician right away. What we need to call for is the fibrinogen that is so depleted, critically low. 88 is very low. Supposedly it should be 200 to 400 milligrams per deciliter. Again, this is reflecting that there is overutilization of the fibrinogen because of the widespread clotting. Alrighty. I hope that you are understanding the explanation on this scenario. Let's move on to number 7. A nurse is caring for a client who underwent a C-section 8 hours ago. The nurse suspects the client may be developing DIC. Which of the following findings should lead the nurse to report to the healthcare provider? Select all that apply. Is it A, or is it 1 rather, bruising on the arm where the blood pressure cuff was applied? 2, heart rate of 130 beats per minute. 3, abdominal incision dressing with moderate serosanguinous drainage. 4, platelet count of 85,000 per cubic millimeter. And then 5, urine output of 300 ml in the past 8 hours. And 6, temperature of 99 degrees Fahrenheit or 37.2 Celsius. What do you think, guys? Please take your pick. We are having a SATA right now. Okay. This is all about assessment. Select all that apply. The nurse suspects the client may be developing DIC. Which of the following findings should lead the nurse to report to the healthcare provider? I'm seeing 1, 2, 4, 5, 1, 2, 4, 1, 2, 4. That's a good sign. All right. 1, 2, 4, 1, 2, 4. Okay. Please take note, guys, about the DIC. That if there is somewhat like ongoing bleeding going on, you will notice this in this patient. All right. Please be careful in selecting the options here. So what are those manifestations? Here is a select all the apply. What are those manifestations that you should report to the medical provider? Those critical signs that will signify ongoing DIC. All right, let's take a look. Bruising on the arm after minor trauma, such as blood pressure cuff application. Yeah, that is one. Selecting that one. This is basically giving us an idea that there is fragile capillaries. They can easily get injured. Then this will form into the bruising, the ecchymosis. There is microvascular clotting. Microvascular clotting. Vascular clotting. What about number 2? Heart rate of 130 beats per minute. Tachycardia, right? Yeah, that's significant. That's a possible sign that there is blood loss that is significant, right? So, a possibility that our patient may have hypovolemia. All right? A compensatory response to hypovolemia. Compensatory response to the blood loss. So we are going to select that as well. What about 3? Abdominal incision dressing with moderate serosanguinous fluid or drainage. What do you think about that? Moderate? Yeah, that's actually suggesting ongoing bleeding. So this is a significant finding. What about 4? Platelet count of 85,000 per cubic millimeter. Yeah, that is also significant. Thrombocytopenia. All right. Common, expected in DIC. What about 5? Urine output of 300 mL in the past 8 hours. Is it normal? Yeah. Normal urine output. So what you're going to do is you're going to divide the 300 ml by 8 hours. And how much is that per hour? What is your answer to the urinary output? What is the hourly output here, guys? If you have 300 ml of urine in 8-hour period, what do you have as an hourly output? What do you think? What is the hourly urinary output if there is 300 mLs in 8 hours? Do you think that is it in the acceptable range of urinary output? Yeah, it is what? 37.5 mLs per hour, or 37.6 or 37.5. It's within the normal range. So we're going to eliminate that one. Eliminate within the urinary output range. So remember about the 30 to about 50 mLs an hour, or 60, acceptable. What about 6, temperature 99? Yeah, within normal limits as well. So we're going to eliminate that. Okay? All right. So we have our answers 1, 2, 3, and 4. So those are the assessment findings that we should be reporting to the medical provider. It did not say immediately, but it said nurse to report to the healthcare provider. Okay? So keep your great work. All right. Thank you. Thank you. Thank you. Let's move on. Everyone, get ready. Surprise, surprise. We have more stuff for you. The situation stated, a 60-year-old male client underwent emergency surgery for a ruptured abdominal aortic aneurysm. Postoperatively, he developed, okay, let's go back really quick to number 3. All right, going back to number 3. Request from Nijay. Abdominal incision dressing. We're not going to leave anyone behind. So, moderate serosanguinous drainage coming from an abdominal incision dressing, right? This is a significant amount of wound drainage. So possibly the dressing here now is actually saturating the dressing. Okay? So simply it means that there is a bleeding going on in the microvascular or in the incision site as well. Maybe the capillaries are actively oozing, right, of blood. Serous sanguinous. Remember about the serous. This is bloody output coming from the incision. So this is a significant indication that there is active bleeding. All right. Serous sanguinous. This is an indication that there is an active bleeding going on coming from that abdominal incision. It is saturating the dressing in moderate amount, right? If it said a shadow, probably would not be concerning, or let's say a tinge of blood, maybe I'll just keep monitoring that dressing. But when it's saying moderate serous sanguinous drainage, this is signifying that there is an active bleed going on. All right, let's move on to the next question, number 8. Here we go. A 60-year-old male client underwent emergency surgery for a ruptured abdominal aortic aneurysm. Postoperatively, he developed signs and symptoms suggestive of DIC. Which nursing interventions are appropriate for managing complications associated? Yes, sir, the client was operated 8 hours ago. I know. So if the client has had that surgical procedure 8 hours ago, and if they still are bleeding, then that is very significant that there is what? An overconsumption of the clotting factors is not able to control the bleeding. Yeah. So it will be a significant amount, serous sanguinous. Yeah, you should not be, was it 8 hours? Did it say 8 hours? Anyway, well, let's go back to that question. Let's move forward with this. Item number 8. Select all that apply. For the cardiovascular, you're going to have the monitor for signs of hypotension, tachycardia, administer diuretics, assess peripheral circulation for signs of ischemia, monitor electrolyte levels, especially potassium. For the respiratory system, you have an option to administer O2 as prescribed, administer anticoagulants. For the neurologic, perform frequent neurological assessments, monitor for signs of stroke or cerebral ischemia, administer sedatives. For the renal system, monitor urine output hourly, assess for signs of fluid overload such as edema. Renal, administer diuretics. Gastrointestinal, assess for abdominal pain or tenderness. Maintain NPO status if GI bleeding is suspected. And lastly, encourage frequent meals. So this is what we call as a matrix multiple response. Okay. So for each system, you're going to click, or let's say put a mark, a check mark, to determine if this is going to be an appropriate nursing intervention for this particular scenario. In our patient here is a 60-year-old male who underwent emergency surgery for a ruptured abdominal aortic aneurysm and now has DIC. So what would be your appropriate nursing interventions in each body system? That's a lot, right? There's 1, 2, 3, 4, 5, 6, 7, 8, 9. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. There's 15 nursing interventions that you can choose for each. For each system, you got 4 options for cardiovascular. So what do you think about the monitor for signs of hypotension and tachycardia? Well, we are going to select that because, as we have known about the DIC, hypotension can be a sign that there is what? Massive blood loss. Same thing for the tachycardia. So this will help us in determining if there is what? A significant blood loss. Let me erase that. Okay. What about the rest? I haven't seen you answering yet. Are you still reading? Signs of significant blood loss. All right. Neji answered cardiovascular 1-3. What about administered diuretics? Administering diuretics to manage fluid overload? No. We're not going to select that. There is no need for us to administer diuretics. The patient with the DIC are prone to developing blood loss, so there's not really a need for us to administer diuretics this time. Assess peripheral circulation for signs of ischemia. Would that be a correct intervention? Of course. We will select that. This is very important. Now, what about monitor electrolyte levels, especially potassium? Is there going to be a need for us to check the potassium this time? Assessment. It's not going to be a primary intervention this time. What we need to do is just to look for the electrolyte imbalances. Potassium is not going to be a specific electrolyte that needs to be monitored in this scenario, so we're going to eliminate that one. Okay? Now, talking about the respiratory, administer oxygen as prescribed. If there is going to be hypoxemia or hypoxia, then we are going to administer O2. That is a good intervention. What about administer anticoagulants? Do you think that we are going to administer anticoagulants? Not such a case when there is a, like in the, what do you call this? It is only reserved to what? Severe thrombosis. So in the usual case, we are going to what? Hold off into the administration of anticoagulants. All right. If it's going to be indicated as severe thrombosis, then the administration of anticoagulants will be warranted. Now, for the neurologic, perform frequent neurological assessments. Would this be appropriate? Yes, because possibly when there is going to be some changes in their neurofunction, we will be able to capture about this significant LOC changes. So we are going to do that. Monitor for signs of stroke or cerebral ischemia. Are we going to do that? Yes, of course. We are going to extensively perform our assessment. What about administer sedatives? Is there a need for us to administer sedatives in a patient with a DIC? And based on the scenario, no, not indicated. We don't see an indication. But guys, you got to be cautious in administering sedatives, benzodiazepines, especially in this patient that may have a higher risk to develop cerebral thrombosis. Caution use of benzo. You got to be careful, guys. If you are administering benzos, sedatives, opiates, you got to be careful. Now, renal, monitor urine output hourly. Do you think this is a good intervention? Yes. Do not neglect that. What about assess for signs of fluid overload? such as edema. Is there going to be fluid overload expected in the DIC? It's not a typical manifestation, and so we are not using this nursing intervention. We are eliminating that one. Not a typical manifestation in DIC. So we are eliminating assessment of fluid overload. What about administered diuretics? Are we going to do that? No. We don't have an issue with fluid volume overload, so we are going to get rid of that as well. Okay? Remove that. Gastrointestinal, assess for abdominal pain or tenderness. This is a very important action because of a possible thrombosis into the abdominal organs. If there is going to be a rupture or a bleed into the arteries or the blood vessels in the GI tract, you have to check this patient's abdominal sounds. Also check for the tenderness. So you're supposed to do that as well. What about maintain NPO status if GI bleeding is suspected? Yes, of course. That is a good intervention. We want to prevent exacerbation of bleeding in the DIC, so we are going to maintain them NPO as indicated. All right. What about encourage frequent meals? Are we supposed to do that? No, we're going to have to eliminate this one. A possibility, we're going to have to encourage, what do you call this? We're going to have to slow down, or actually possible NPO in this patient with a, what do you call this? Involvement of thrombosis in the GI tract. So we are going to eliminate encouragement of frequent meals. Last one is a no. Okay. All right. How are you doing, guys, as far as your performance with this test item? How are you doing so far? Are you getting more correct answers? All right. Let me move forward with, yes, NPO is to rest the bowel if there would be involvement of the GI tract. Okie dokie. Let's move on to question number 9. A nurse is educating. Okay, before I go to do that, again, we are promoting our NCLEX course in our website at Stancoast NCLEXcoaching.com. Make sure to pay us a visit at our website so you can know more about us, or click into the description box below for more details. We have the on-demand videos that will help you out with your own study. Our test questions include 3,000 NCLEX test questions plus 200 NGN test questions. And there's going to be more perks as far as the study guides that we'll be offering as well. So please check our website. Okay, learning every day. That's very good. That's good. Good. Let's tackle this number 9. Statements of a student. So a nurse is educating a group of nursing students about the pathophysiology of DIC. Which of the following statements accurately describe the pathophysiology of DIC? Select all that apply. One statement is DIC is characterized by abnormal activation of the coagulation cascade. 2, microthrombi formation occurs throughout the microcirculation. 3, the condition leads to the depletion of platelets and coagulation factors. 4, fibrinolytic mechanisms are suppressed, preventing hemorrhage. 5, DIC commonly results from infections, obstetric complications, or major tissue injury. 6, end organ infarction is uncommon in patients with DIC. 7, commercial. 7, elevated fibrinogen levels are typically seen in DIC. 8, hemorrhage and thrombosis occur simultaneously in DIC. Take your pick. We are dealing with a SATA question. All right. Please select your answers. Number 1, let me start answering here. We don't want to run out of time. DIC is characterized by abnormal activation of what? Coagulation cascade. All right, is that correct? Yeah, this is correct. Abnormal activation of the coagulation cascade. This is going to cause the clotting process into an overdrive. This is like overdrive or hyperactivation of the coagulation process. So that is why statement number 1 is correct. What about 2? Microthrombi formation occurs throughout the microcirculation. Of course, thrombi, micro. There's your clue. That is correct as well. The thrombosis in the capillaries, right? Yeah, that's an easy find. It can block the blood flow. Blocks blood flow. It can cause tissue ischemia. All right, what about number 3? The condition leads to the depletion of platelets and coagulation factors. Yeah, that's a given. Correct. Remember about the DIC? Because of that former or initial injury to the endothelium, or let's say injury to the muscle tissue, or let's say sepsis, the coagulants or the clotting factors rather, or the platelets will be called to congregate into the site of injury, and this will now be depleted. All right, so there is poor replenishment, or there is decreased replacement of these clotting factors and the platelets. There is now depletion. The word here is depletion of the platelets and coagulation factors. What about number 4? Fibrinolytic mechanisms are suppressed, preventing hemorrhage. Well, there is no prevention of hemorrhage in the DIC itself. The pathophysiology stated that there is what? Hemorrhage. So this is wrong. This is wrong. It's not suppressed, right? It isn't, okay? Actually, the fibrinolysis is activated. Fibrinolysis is activated, right? It is activated. This will lead to the bleeding problems. So this is going to be wrong. What about number 5? DIC commonly results from infections, obstetric complications, or major tissue injury. That's what basically we talk about. All right, so this is also correct. What about number 6? End organ infarction is common or is uncommon. The word here is uncommon. Is that correct? No, it isn't. It makes that statement wrong. It's common, not uncommon. So what is going on in DIC? There is going to be infarction and also damage to the organs because of the decrease in the blood flow, because of the thrombosis, especially in the kidneys, the liver, the brain, the lungs. So this will lead to the tissue damage or organ damage. Number 7, elevated fibrinogen levels are typically seen in DIC. Elevated? No, it is decreased. This is wrong. Oh, thanks. Thank you, Farhana. Very good that you're learning. Thanks for attending our class. Okay, what about number 8? Hemorrhage and thrombosis occur simultaneously in DIC. Is that correct? Yes. Both the hemorrhage and the thrombosis can happen at the same time. And the thrombosis is going to be excessive, and also the bleeding is also excessive. So it will be a vicious cycle between the two at the same time, simultaneously. Yeah. So this is going to be a huge problem in the IC because it is continuous thrombosis, continuous bleeding. 5 out of 5. Wonderful. That's good. What about the rest of you guys? Are you getting the decent amount of correct answers? Guys, these are high-level questions, guys. These are not easy questions to tell you. So if you are getting 75% out of the total score, you're doing great because these test questions are not easy. I'm just telling you that I like to make my questions harder. And that's what my students dislike most of the time. Just kidding. All right. So please review the concept of the DIC. Again, our correct answers. What are those answers? We have 1, 2, 3, 5, and there's also what? 8. 1, 2, 3, 5, 8. So those are the correct descriptions of this DIC. All right, 1, 2, 3, 5, 8. So I just want to make sure that this is retained in your subconscious. Let me go back into that pathophysiology again. 687. Let's go back into here. Always go back into the pathophysiology if you don't understand the mechanisms. Okay? Take a look here. Pay attention. When there is injury, right here, this will cause the aggregation of the platelets and also the clotting factors. Okay? There's that breakdown of the products. So there is now reduced clot formation, bleeding tendencies. Right? There is also that hemolytic anemia. Remember about that passage of the red blood cells? When they pass through that narrow capillary where the thrombosis is going on, there is going to be... Will this lecture be provided after class? Yes, this live stream is available at our website. In the live tab, you will see all the lectures that we have done in the past 39 days? Yeah, 39 days. It's been that long, guys. So you can check out our website. Do you know how the board asks? With, yes, I know. And so the board examination right now with the NCLEX, actually the way that they're asking the test takers right now, it seems like they're wanting for you to really understand the mechanism, the pathophysiology. I've never seen such kind of test questions in the past about the drop-down menu, what is the underlying mechanism, something like that, the association between the manifestation and the cause for this. And basically, they want really to assess your basic understanding about the disease process, right? And so we want you to go back into the original concept. How is the disease happened? How is that progressing? Okay, because if you do not understand the disease process, then you will not be able to prioritize your interventions. You will not know what to deal with. So that is why you have to go back to the pathophysiology. Okay. Platelet usually elevated in DIC. During therapy, it should be decreased. No, it's not elevated in the DIC AGI. Remember that there is going to be aggregation. With the vessel injury, it will require all those platelets that it can find in the circulation. Hey, we want you here. We want you to go into this area of injury. So the circulating volume or the circulating amount of platelets will be consumed really rapidly. So it will be decreased in amount. Thrombocytopenia, remember? Thrombocytopenia. Okay, Let me rewrite that. So what are the things going on in DIC? Thrombocytopenia. There's also decreased clotting factors. Please don't forget that. During therapy, it should decrease. When there is now the management of the DIC, if we are dealing or if we are treating the infection, if we are treating the patient with the clotting factors like the FFP, the cryoprecipitates, if we are treating the patient with platelets, transfusion, or let's say red blood cells, then of course the platelet will start to go up. It will normalize, right? We don't want to decrease the platelet, okay? There is already a thrombocytopenia going on. We don't want it to decrease. We want to treat the thrombocytopenia. Alrighty, let me go back to that. Let's see what is going on. So, I think we finished number 10, right? I would need to stay. No, not yet. So, no, not that one. We are in item number 9. Microthrombi, blocks blood flow, tissue ischemia. I think we are done with number 9. So let's move forward to item number 10. A nurse is discussing the care plan with a patient who has been diagnosed with DIC. Which of the following statements made by the patient indicate correct understanding of their care? Select all that apply. Statement made by the patient indicating correct understanding. Is it 1, I should avoid using tape on my skin whenever possible to prevent bleeding? 2, I will monitor my pad count and saturation during my menstrual cycle. 3, if I notice any internal bleeding, I should immediately lie down and rest. 4, it is important to keep warm to help with blood flow. And 5, I should change my position frequently to promote circulation. 6, I can use over-the-counter vasoconstrictive agents if I feel cold. And 7, I will need to stay in bed during any bleeding episodes. And 8, I should apply pressure for at least 5 minutes. I should apply pressure to any bleeding site for at least 5 minutes. We are confused how to in this question. Okay, let me know, AGI, which question you're referring. Is it number 10 or is it number 9? So if you are talking about number 10, it's asking you to select those statements that show evidence of understanding about their care. Again, this test question is going to ask you to identify which of the following statements or the statements made by the patient that they understood the care that they should be receiving. So we are seeing 3, 4, 5, 8 from Virtuous Lady, 1, 2, 5, 7, 8 for Mary, and 1, 2, 5, 8 from Miss Flynn. Ms. Flynn. 1, 2, 5, 8. So let's take a look, guys. Number 1, I should avoid using tape on my skin to prevent bleeding. Yeah, that is a correct statement. Avoiding the use of the tape on the skin can help prevent dislodging the blood clots that will cause additional bleeding. So this is very crucial for this patient to understand. Avoid use tape on skin whenever possible, because when they're going to if there's going to be tape application to the site, and if they're going to remove that tape, it can possibly dislodge that clot and will there will be additional bleeding. Okay. What about number 2? I will monitor my pad count and saturation during my menstrual cycle. Of course, right? That is a sane intervention or sane statement. Yeah, I am aware that I'll be bleeding more during my men's period. So I should watch for my pads. Okay? This is a good statement from the patient. What about 3? If I notice any internal bleeding, I should immediately lie down and rest. This is incorrect. Why? Instead of lying down, they should inform the healthcare provider immediately. Immediately inform. I'll just use the word notify the medical provider. All right? Immediately lie down and rest. It's not addressing the issue. So they should notify the medical provider in order to let them know that something is going on, that they're actively bleeding. They might need to have some emergency procedure to stop the bleeding. What about number 4? They need to be taught to go to the ED right away. Yes, that's correct. ED and call the doctor, or call the doctor, I should say. Number 4, it's important to keep warm to help with blood flow. Do you think that is a good statement? Yes. We want to make sure that they are going to have that warm temperature to allow adequate blood flow, especially that they are at risk to developing thrombosis. This is correct, guys. Correct. Maintain blood flow. We don't want blood flow. We don't want any vasoconstriction into this patient. All right. Blood flow. Yeah, my vision right now is quite limited with all these very tiny fonts trying to accommodate. Sorry about that. Number 5, I should change my position frequently to promote circulation. Yeah, of course, right? We don't want to add more issue like DVT. So, or let's say skin breakdown. Prevents skin breakdown. Or it can also prevent DVT, right? Positional changes. What about number 6? I can use over-the-counter vasoconstrictive agents if I feel cold. Vasoconstrictive agents. Is that going to be counterproductive? We don't want that simply means that it's going to be contraindicated. Contraindication. Vasoconstrictive agents. We don't want those. All right. So, cold packs will be avoided. And those containing like epinephrine, no, we don't want that preparation to stay in contact with the patient's skin because it can cause vasoconstriction. Cold packs, epinephrine, topical epinephrine should not be applied to the patient's skin. But we're talking about over-the-counter. I'll eliminate the epinephrine anyway. But yeah, cold packs will be contraindicated here. Number 7, I will need to stay in bed during any bleeding episodes. What do you think about that? I will stay in bed during the bleeding episodes. Of course, bed rest is going to be important right now because it can prevent further bleeding. That's a good intervention. What about number 8? I should apply pressure to any bleeding site for at least 5 minutes. 5 minutes? That is not enough, guys. In a patient with the DIC, the pressure should be at least 20 minutes. It should be prolonged, not 5 minutes, in order to stop the bleeding. Okay, so the duration of the pressure application will be at least 20 minutes, not 5 minutes. That's why this is going to be a wrong option. Okay, learning more than giving answers. All right. Okay, I hope that you're getting some more correct answers this time? I hope so. Let's move forward to number 11. I got more surprises for you. 11. A patient diagnosed with septicemia experiences prolonged bleeding from the venipuncture sites and blood in the stools. What should the nurse prioritize? 1. Refrain from further venipunctures. 2. Apply dressings to the bleeding sites. 3. Notify the healthcare provider. And 4. Administer prescribed proton pump inhibitors. A patient diagnosed with septicemia experiences prolonged bleeding from venipuncture sites and blood in the stools. What should the nurse prioritize? Is it 1. Refrain from further venipunctures. 2. Apply dressings to the bleeding sites. 3. Notify the healthcare provider. 4. Administer prescribed proton pump inhibitors. What is your answer here? Septicemia experiences prolonged bleeding from venipuncture sites and blood in the stools. I'm seeing Virtuous Lady answering 3, Charity as well. You changed your answer, Virtuous Lady, to 2? Why did you change your answer? Oh boy. Okay, look at that scenario. The patient diagnosed with septicemia experiences prolonged bleeding from the venipuncture sites and blood in the stool. What should the nurse prioritize? Are you going to do 1? Or are you going to apply dressing to the bleeding site? Or are you going to notify the healthcare provider? Or are you going to do number 4, administer prescribed proton pump inhibitors? Okay. So I want you to carefully select your answer here. Will an application of dressing stop the bleeding? A mere application of a dressing will not stop the bleeding. Pressure will stop the bleeding or will minimize the bleeding. 20 minutes. Application of dressing will not. All right? Will not stop the bleeding. You're just applying the dressing here. No pressure. Okay? So it's not going to be helpful. What we're looking for here is that nursing action that would alert the medical provider because our patient has significant changes. Blood in the stool. That is GI bleed. Venipuncture site has prolonged bleeding. It did not say that it's going on like right now, but we are notifying the doctor that this is happening in our patient. We need to notify them. Notify the medical provider. If we are going to answer number 1, refrain from further venipuncture, it's a good intervention, but is it going to alert the medical provider? No. The priority here is to make sure that the medical provider is aware that something worse is happening in our patient. There is GI bleed, prolongation of the bleeding. We can do as a secondary action, not a primary action. What about 4? Administer prescribed proton pump inhibitors. That would be a possible treatment, but will it be the primary intervention for this one? No. We are going to have to notify the medical provider first. Okay, so this is going to be a secondary nursing action. Okay, prolonged bleeding from the venipuncture and also blood in the stools. All right, so applying dressing will not do that. Stopping, it will not be helpful if you are not applying pressure. Refrain from further venipuncture is also a good intervention, but it's not as critical compared to notifying the medical provider. 4 is also a good intervention. However, it will not take place prior to the notification. It will be ordered possibly once we have notified the medical provider. So try to eliminate those options properly, guys. Number 12. A patient suspected of having DIC arrives in the ED with a blood pressure of 85/42, temperature of 101.5 Fahrenheit, 38.6 Celsius, and severe back pain. What action should the nurse prioritize? Is it 1, administer morphine sulfate 4 milligrams IV? 2, give acetaminophen Tylenol 650 milligrams. 3, infuse normal saline 500 mL over 30 minutes. And 4, schedule complete blood count and coagulation studies. A patient suspected of having DIC arrives in the ED with blood pressure of 85/42, temperature of 101.5 Fahrenheit, 38.6 Celsius, severe back pain. What action should the nurse prioritize? Is it 1, administer morphine sulfate 4 milligrams IV, give acetaminophen Tylenol 650 milligrams, 3, infuse normal saline 500 mL over 30 minutes, and 4, schedule complete blood count and coagulation studies? Thank goodness I'm seeing 3. Yeah. Very clear description of a patient that has ongoing bleeding with hypovolemia. This is a classic hypovolemic shock. Yeah, good thing I did not add the heart rate here, because if probably I added the heart rate, I probably would put 150 or 140 beats per minute. So we are going to prioritize infusion of a bolus. IV. We are going to address the hypovolemia. We need to maintain. The goal for the bolus is to maintain perfusion or improve perfusion to the vital organs. And tissues. All right, this is already low, guys. When your patient has a low blood pressure like this one, this will compromise the blood circulation to the important organs in the body. And if we are not going to treat this immediately, this can lead to so many things. Renal failure. Your patient probably going to end up with a anoxia, decreased oxygenation to the brain and other organs like the liver as well. So we need to treat this immediately with a normal saline bolus of 500. Even the 500 is not even enough. I've delivered boluses in the past, like 2-3 liters in a patient that has hypovolemia. And you got to be on your toes around this time when you are treating the patient with sepsis. Or let's say, for example, disseminated intravascular coagulation. Look at this one right here. Severe back pain. What is this severe back pain going on? The severe back pain is actually a possibility of a retroperitoneal bleed. Bleeding in the kidneys, probably, okay? So this is an emergency. We need to keep an eye on this guy. This patient has to be treated now, okay? We're not going to delay any treatment. If we're going to administer morphine sulfate, I know this is an analgesic, this is an opioid. But we know that the opioid can cause further hypotension. We're going to have to deal first with the blood pressure. Okay, we're going to have to stabilize first the circulation. What is the problem here in this test question? Circulation. All right. Yeah, large bore IVs. 2 large bore IVs. Okay. So here we have our problem with circulation. Prioritize that one. Okay. don't forget to apply the ABCs. Airway, circulation and breathing. Okay? Don't forget that. So this problem right here is about circulation. We need to deal with that one. Not morphine sulfate. If we're going to do number 4, schedule complete blood count and coagulation studies, yeah, that is another secondary nursing intervention or to evaluate. But if we are going to have this patient that has suspected DIC, treat the hypotension right away. All right? That would be our priority nursing action. All righty, let's move on to, you've worked in the ED, James? Very good. Yeah. Even in the med-surg, if you're going to encounter a whole lot of like drastic changes in your patient, yeah, I've encountered way too many like just bizarre patient experiences. It's fun to work in the med-surg. All right, we have number 13 item. So what do we have here? This is what we call as the matrix multiple response. So basically what you're going to be doing here is to select or do your check marks or X marks. You're going to have to indicate whether the thrombocytopenia, the bleeding, the thromboembolic events, normal coagulation studies are going to be appropriate for the different disorders. Are they going to be, are these assessment findings appropriate, or are these assessment findings seen in the heparin-induced thrombocytopenia? Is this seen in the idiopathic thrombocytopenic purpura, or is it going to be seen in thrombocytopenia, or is it a manifestation in DIC? So this is going to be your task right now. So a nurse is taking care of a patient diagnosed with disseminated intravascular coagulation. The nurse needs to identify clinical features that are shared and not shared between heparin-induced thrombocytopenia, idiopathic thrombocytopenic purpura, thrombocytopenia, and DIC. For each clinical feature, click to specify if the finding is consistent with HIT, ITP, thrombocytopenia, and DIC. So each of the clinical features may support more than one condition. Oh, welcome, Saima. Welcome to the class. Yeah, you are free to actually join us every day. And we have already done 39 sessions in the past 39 days. So, guys, I want you to start answering this test question. There are 10 clinical features that you're going to identify if they are going to be seen in heparin-induced thrombocytopenia. Are they going to be seen in ITP? Are they going to be a common manifestation in thrombocytopenia? And are they going to be seen in DIC? Guys, start answering, because I'm going to have to start explaining the different items. So, thrombocytopenia. This is basically the what? Low platelet count. And this is going to be present on what? Low platelet count. It's going to be present in heparin-induced thrombocytopenia, the ITP. It will also be assessed in a patient with thrombocytopenia, of course. Thrombocytopenia, this is also thrombocytopenia. This is also thrombocytopenia. Heparin-induced thrombocytopenia. This is idiopathic thrombocytopenia purpura. And we have the classic thrombocytopenia. And plus the DIC, right? What is going on in the DIC? There is overconsumption of the platelets because they are needed into the site of injury. So there is going to be a depletion of the platelets. So all of the 4 disorders will have thrombocytopenia. Now take a look on the bleeding. Now you got to be careful with this one. Bleeding. Do not apply the bleeding on every disorder here, guys. Be careful. So what would be the disorders that will manifest the bleeding? Take your pick. Take your pick. So the bleeding is a clinical feature in ITP. It is also seen in a classic thrombocytopenia and also DIC, but less common in HIT. Not common. Why? Remember about the HIT, the heparin-induced thrombocytopenia? Do you remember about the reason? Remember that it can cause the thrombosis, not bleeding. Yeah. There is bleeding despite, oh no, there is, in HIT, there is thrombosis despite low platelet count. Thrombosis despite low platelet count, which is totally different with a DIC. Remember, with a DIC, simultaneously it will have thrombosis, but will also have the bleeding at the same time. So that is why we have the bleeding consistent with the DIC, thrombocytopenia, ITP, but not HIT. Please keep that in mind. There is thrombosis only in the HIT. Now, thromboembolic events. What do you think about the thromboembolic events? This is basically the migration of the clot into the body tissues, maybe the lungs, maybe the migration of the clot into the brain, the cerebral blood vessels. So what do you think in thromboembolic events? Yeah, it can be assessed in, or it is common in HIT, because in HIT, it can promote the development of the antibodies, it will activate the platelets, and it will lead into thrombosis. So that is why HIT have that one. However, what else? In DIC, is there also thrombosis? Yeah. What about ITP? Is there going to be thrombolic events in ITP and thrombocytopenia? No. So this is going to be none. There's also none here. Thromboembolic events will be common in the DIC and the HIT. Now talking about the normal coagulation studies. Yep. Are you answering correctly this time, guys? Let me know. Because if you are, that's very good. You are thinking. Number 4, normal coagulation studies. This is going to be reflected in ITP, normal coagulation studies, and also in ITP and also thrombocytopenia. However, the normal coagulation studies is not found in HIT and DIC. No, also no here. There is going to be increase in the PT, also the PTT. Remember that, guys. Increase PT, increased PTT. Same thing here with the DIC. There's also elevation of PT and prothrombin time. Okay, let's move on with number 5. Microangiopathic hemolytic anemia. So what does this mean? Microangiopathic hemolytic anemia. Remember about that thrombosis? I described this earlier, when the blood clots are lodged into the blood vessels, and then our red blood cells will be circulating into these areas where the blood clots are. These are going to be hemolyzed. There is going to be increasing hemolysis. All right. So is this going to be seen in HIT or ITP or thrombocytopenia or DIC? No, not on everyone. It will be seen in the DIC. Let me remove that. Okay. We will be seeing that here in the DIC. No, no, and no. What about heparin exposure? What did we talk about yesterday on the heparin-induced thrombocytopenia? Remember about the HIT? Well, of course, it will require that person to be exposed to the heparin. So this is only seen in a patient with HIT, but not on ITP, not on thrombocytopenia, not on DIC. What about number 7, immune-mediated platelet destruction? Remember about what I mentioned yesterday about the Helicobacter pylori infection? That was just one example. Remember about that there is going to be an immune-mediated platelet destruction. It will target the platelets. And so this is only going to be seen in ITP. All right? Not on HIT, not on thrombocytopenia, not on DIC. All right. What about elevated D-dimer, which is basically that lab value that will determine that there is a rapid rate in the breakdown of the clots? So what would be that problem that is associated with? So we're going to have the immune-mediated platelet destruction. So this is going to be specific to the DIC. Okay, D-dimer elevation, only specific to the DIC, not in HIT, not in ITP, and not in thrombocytopenia. Okay, D-dimer. Remember that there is rapid rate of breakdown. Rapid rate of clot breakdown. There is no rapid breakdown of the clot in HIT. None. Not even in ITP, not in thrombocytopenia. It's only seen in DIC, guys. Okay, D-dimer is elevated. Now take a look on petechiae. Is petechiae common on all 4? Yeah? Well, remember that the patient with ITP can manifest this one. Let me just erase this because this is getting too busy. So petechiae is common in patients with ITP. Okay. And the same thing with the classic thrombocytopenia. It will be seen here as well. And also the DIC. All right. However, it will not be particularly seen in the HIT. Remember that HIT has a problem with thrombosis, not really the bleeding itself. So this is going to be no right there. And then we have autoantibodies against platelets. Remember about that mechanism, about autoantibodies against the platelets. It will be seen in idiopathic thrombocytopenic purpura, but not in HIT. And also not found in thrombocytopenia, that is classic, and not found in DIC. All right. Guys, how is this test question for you? Is it helping you recall the clinical manifestations, especially with the 4 bleeding disorders? I hope that you are learning from this one, because this is very important for you to manage your patient accordingly, because they have variations in their assessment findings. Okay, so make sure that you go back into this lecture to focus into those areas that you had committed errors. Now let's move on into number 14. This is another matrix multiple choice item. The question states, A nurse is caring for a patient suspected to have a bleeding disorder and is considering various medical management options. So I want you to differentiate the appropriateness of the following treatments for patients with suspected HIT, ITP, thrombocytopenia, and DIC. All right. So your role here is to identify if the following treatments are appropriate for HIT. Is it appropriate for ITP? Is it appropriate for the classic thrombocytopenia, or is it going to be an expected treatment for the DIC? Number 13 was really tough. Yeah, I know that was really tough. I took time to really look into those answers because it can be so tricky. I could commit an error in assigning those boxes. I was sweating hard just creating that question. All right. So what would be your answers here? We have 6 different treatments assigned. So I want you to identify if one is applicable to HIT or the rest of them. Is the glucocorticoids applicable to HIT, ITP, thrombocytopenia? Is the immunoglobulin IV, is it applicable to HIT? Or the thrombopoietin receptor agonist, or the cryoprecipitate transfusion, or the fresh frozen plasma transfusion? So I really want you to recall those concepts that you had learned yesterday about the platelet disorders. All right. Okay, how can I watch? Let me send you the link right now while the rest of you guys are answering the test questions. Let me go to that. Live sessions. "13 was interesting but draining." Yeah, I know. It's draining. You really have to use your brain cells to answer the correct, to get the correct option. Let me go back to that. Wait a second. Stancoast. Oh, very good, James. Thank you. Thank you. Let me send the link for the streams for you. Wait a second. Where's my chat box? Here we go. So please don't forget to enroll in our NCLEX Review Course at our website at stancoastnclexcoaching.com. And Chichi, I sent you, oh no, it wasn't you. I believe it was Saima. Okay, Saima, the link for the previous live sessions is now posted in the chat box. Okay, so please check that out. All right, so where are we at? We are on this test question. Monica answered 1 for all. Okay, platelet transfusion. Is platelet transfusion appropriate on everything? You're welcome, Saima. Remember about the concept that we had yesterday. We're not done yet. Okay. Do you think platelet transfusion is going to be applicable on all 4 of these disorders? Remember, guys, that when we are going to deal with the platelet transfusion, this is going to be appropriate with what? The thrombocytopenia, also the DIC, okay? However, it will not be used in HIT. No. Why? Why is the platelet transfusion contraindicated in HIT? Remember about the explanation about that. When we are going to give them the platelet, it is going to worsen the clotting issues, because in HIT we know already that there is thrombosis, not bleeding. So this is the weird bleeding disorder here. There is thrombosis in HIT, but not bleeding. So if we're going to, even though if their platelet is low, I know that there is thrombocytopenia. You will get fooled that, hey, my patient will end up bleeding because they have very low platelet count, but it doesn't end there. The body is actually causing the activation of more platelets, which will lead to more thrombosis. So this is a big problem in HIT. It's not the bleeding, guys. So if you're going to give more platelets, if you're going to transfuse platelet to this patient with a HIT, the more that there is going to be thrombosis risk. So no platelet for the HIT. What about glucocorticoids? What do you recall about the glucocorticoids that we talked about yesterday? This is going to be useful in the treatment of ITP, because in ITP, this is caused by what? The immune system's attack on the platelets. Immune system is attacking the platelet. So this is only applicable to the ITP, okay? Also will be utilized in the thrombocytopenia, but it's not going to be useful in the HIT and the DIC because there's no immune system involvement in the other two. So this is only going to be indicated for the ITP or the idiopathic thrombocytopenic purpura, or possibly the thrombocytopenic classic. All right. Now, talking about the immunoglobulin, IV immunoglobulin, is this going to be appropriate for this patient with HIT? No. There is no such indication of IVIG in, hang on a sec. The IVIG is only indicated in this one, ITP. Remember that it's caused by immune system dysfunction. It's attacking the platelet. And again, the immunoglobulin will be used if the person is not responsive to the steroid therapy. Okay? Again, immunoglobulin will be the next step of treatment if they're not responsive to the glucocorticoid. So this is indicated here for ITP, but not in the DIC. And thrombocytopenia, no for the HIT as well. Now, what about the thrombopoietin receptor agonist? What are these medications? The thrombopoietin agonists, or known as the TRA, they are known to what? Stimulate production of platelets. Stimulation of platelet production. So this is only going to be applicable into the following disorders. We have the ITP and also in a patient with the classic thrombocytopenia. Now, why isn't it not used in the HIT and the DIC? Well, the reason because there is no dysfunction in the platelet itself, okay? There is no, the problem originally was caused by something else. It's not about the platelet. So that's why it's not going to address the problem, okay? So this is a no for both DIC and HIT. What about cryoprecipitate transfusion? What do you think about that? Clotting factors. So the cryoprecipitate will contain fibrinogen, which is lacking in DIC. So this is going to be useful here in the DIC, okay? And it's not going to be indicated in thrombocytopenia, not indicated in ITP as well, and it is not indicated in the HIT as well. Because as we know that fibrinogen deficiency is only seen in the disseminated intravascular coagulation. Now take a look into the last one, number 6, fresh frozen plasma, which is that blood product that contains the various clotting factors. It will correct the coagulation abnormalities. So this is going to be used in what? The DIC, all right? But it's not going to be used in ITP, not as well in the thrombocytopenia, and it's not going to be used in the HIT as well, as we know that there is no problem in the coagulation in the HIT. All right, so this is not going to be applicable as well. Only the DIC. All right. Oh boy, that was quite a lengthy one. Fresh frozen plasma, again, will contain those clotting factors that are deficient in the DIC. There is no deficiency in the clotting factors in the heparin-induced thrombocytopenia. None. What happens in HIT is basically the aggravation of the platelets. It's going to run out of the platelets. I mean, because of the heparin exposure, it will develop antibodies, and it will now cause activation of more platelets, which will lead into what? Thrombosis, more clotting. Okay, so it's not going to be a problem in the coagulation component. So it's not going to help this patient with HIT. Now let's do the last one question here. I hope that you were learning with the number 14 because that was also complex. But let's move on with the last one. A 42-year-old female patient diagnosed with disseminated intravascular coagulation presents with complaints of severe bone pain, chest pain, and decreased urine output. She is at risk for developing bleeding, impaired tissue perfusion. Which of the following nursing actions are appropriate for managing her condition? Select all that apply. Is it 1, institute bleeding precautions, 2, administer blood products as prescribed, 3, avoid dislodging clots and apply pressure to bleeding sites, 4, monitor for signs of vascular occlusion, and 5, avoid frequent position changes and range of motion, and 6, apply vasoconstrictive agents such as cold packs and topical epinephrine. So we have select all that apply as our last question today. Patient is still with a DIC with complaints of severe bone pain, chest pain, decreased urine output, oh boy, at risk for bleeding and impaired tissue perfusion. Which of the following nursing actions should or are appropriate for the management of her condition? So I'm seeing Mary answering 1, 2, 3, 4. Okay. 1, 2, 3, 4 from Miss Charity. So 3, 4. Okay. So I think this is a given. Very good. I'm seeing lots more of the 1, 2, 3, 4. Okay. So our correct answers for this SATA questions are the following. We're going to what? Institute bleeding precaution. Of course. That is correct. Again, the disorder is characterized by simultaneous bleeding and thrombosis. This is a correct intervention. We need to what? Teach the patient on bleeding precautions, use of soft toothbrush, avoid IM injection. So let me list them down here. Avoid IM injections, avoid unnecessary venipunctures. What else? We're going to have to provide them with a electric shaver if they are a male person that needs to be shaving their beard. Electric shaver. What else? Soft bristled toothbrush. Always remember this, guys, because This can be asked in the NCLEX. Very simple interventions, but very critical, guys. Avoid dental flossing. Avoid flossing. We're also going to have to soften stools. All right, soften stools. So possibly an increase in the dietary fiber and also the use of laxative to prevent straining. Alrighty. Now, what about number 2? Administer blood products as prescribed. Yes, of course. We're talking about DIC. What are those blood products? Possibly the cryoprecipitate, could be the FFP, or could be platelet. This is FFP. Whoops. FFP. James, why are you putting Y? What does that mean? Are you asking a question? Why? FFP. There's also what? That cryoprecipitate. Avoid NSAID. Yes, that's correct. Very good. Thanks for that suggestion. Avoid NSAID. Avoid the ibuprofen, aspirin. Those are NSAIDs. Okay. FFP cryoprecipitate could be platelet transfusion. What about this one? Avoid dislodging clots and apply pressure for bleeding to bleeding sites. Correct. We already talked about that earlier. Number 4, monitor for signs of vascular occlusion. That is also one of the nursing interventions to note. So we're going to assess for the pain, maybe joint pain, the coolness of the extremities, the color changes of the extremities, so we can address them promptly. So that's another correct answer. What about avoid frequent position changes in an ROM? Well, the word avoid makes this statement wrong. We should not avoid the patient or prevent the patient from doing frequent positional changes. They need to, okay? This is to prevent skin breakdown. And also we need to prevent what? DVT. Because of the thrombosis that can potentially occur to them. What about number 6? Apply vasoconstrictive agents such as cold packs? No. We're supposed to avoid that one, not apply. So both 5 and 6 are wrong options. So we are left up with 1, 2, 3, and 4 correct answers. Alrighty. 1, 2, 3, and 4. So I hope, guys, that you're learning today with the complexities. It was really hard to look for these test questions in the books, textbooks. I looked everywhere. And most of the questions there about DIC are mostly about MCN, maternal and child nursing. I cannot even recycle those. And so most of these test questions are actually brand new, especially the matrix style, the multiple choice. I really made sure that all those manifestations, the treatment have been based on the textbook itself, because I cannot find any of those in the NGN textbook. No, not even with the other companies that I've worked with. No, I cannot find those. And so make sure that you're going to review this video, because this will help strengthen the concept as you're going to go back with all the topics that we have talked about yesterday about the platelet disorder. Please do so. I want you to go back into those concepts, because most of the test questions that we did today are in combination with both coagulation disorder and also this one. And so please rewatch those lectures, so it will strengthen the concept, okay? It will help you retain those important explanations and also the assessment findings, the treatment. I know. Myself, guys, I try to just make sure that when I took the NCLEX, let me share my experience. I did my own review for the NCLEX exam back in 2005. That was way back then. How many years ago was that? Almost 20 years? Yeah. I did my own study. I I bought like an online course for the test questions, but that was it. Um, I didn't know, I mean, so many of the concepts, I lacked some understanding. And so I have to go back into the textbooks. I use different resources, different reviewers. And after each, I go through the concept. I would really test myself, do the same kind of test questions. So, for example, if I'm studying about DIC, then I will have to look for those test questions regarding DIC so that I will know for sure if I retain the concept. Okay, so I would advise that you would do the same when you are doing your own downtime or when you are doing your own study. Make sure that you gauge yourself as well. You do your pre-test, you do your own post-test. That is just one technique that you can do aside from the offerings that we are giving you. But again, I would rather be ready and study those hard concepts rather than not preparing, because who knows what can come out of the exam. We don't know. We really don't know. Even though some people would say, hey, these are the high yield test questions that come out on the exam. No, there's no guarantee. And I've been into that scenario that I only studied the high yield topics that they said to be high yield, but actually it's not true. Some of the test questions that came out of the exam were items that I was not able to study. So I would rather recommend that you prepare for the NCLEX and get some better coverage rather than just focusing on a few topics, because there's no reassurance, guys. There is none. Okay? So make sure you do your preparation, diligent study. I would rather do more than not having to prepare myself. So that's just my advice for you. Maybe it will work for some others. Maybe they're going to be lucky in taking the exam without studying way too much. Well, lucky for them. But for me, I would rather be prepared rather than not. Okay, so that's just my 2 cents. Yeah, we'll see you again tomorrow. We'll be talking about what? We'll be talking about coagulation disorders. We are not done yet with the hemophilias A and B. I know that they are common in childhood, but we'll be tackling those hemophilias A and B and some more NCLEX questions. So I'll see you tomorrow at 9 p.m. Eastern Time. And thank you for your participation. You take care and have a great day ahead. Bye-bye.